Hello and welcome to the Spring Retina Update 2023. Thank you for joining us. All callers will be in listen-only mode throughout today's event. As a reminder, today's call is being recorded. We do encourage you to submit questions throughout the webinar using the Q&A panel. If you experience technical difficulties, please reach out using the Q&A panel and I will assist you. If you've closed the panel, it can be reopened by clicking the Q&A icon again at the bottom of your screen. With that, I'd like to turn things over to Dr. Bradley Smith from the Retina Institute to kick off today's call. Dr. Smith, you now have the floor.
Thank you, Jen, and thank you everybody for attending our 9th annual Spring Retina Update. On behalf of all of us at TRI, I would like to welcome you this morning. This meeting is made possible by a grant from the Retina Research and Development Foundation. And if you are aware of that, you know the good work they do in funding educational events like this, as well as clinical research, and also the education of future retina specialists via our Retina Fellowship program at the Retina Institute. This program is fully accredited by the ACCME. Credits are available for medical doctors, optometrists, and technicians seeking JCAPO credits. We have done our best to avoid any influence from commercial bias, and all potential forms of bias have been mitigated. This is the disclosure information for the Conference Planning Committee, and I'd like to thank my committee members, Dr. Durrani, Nancy Bolosky, Stacy Dice, Fred Loper, who is with InMed, who will do the accreditation, as well as others who have been involved on our staff, including Mike Herendine, who runs our IT department, and Dave Yates, who assists with some graphics. The learning objectives today are listed below, and the disclosure for each speaker is listed here and here. And this will cycle through during the break as well, if you're interested. This is the most important slide you'll perhaps see today. To claim your credit for attending this morning, you're going to receive an evaluation form via email. So watch out for that, watch your inboxes, check your spam folders. The evaluation must be completed and returned no later than May 14th in order to receive credit. And then shortly thereafter, you should receive a confirmation with a credit certificate. If you have any questions, please reach out to Nancy. This is also important for technicians and only the technicians seeking JCAPO credits. There's a quiz that you must complete and answer a minimum of 80% of the questions. If you need help, please reach out. Here's our agenda, and we'll start off the morning with our first speaker, my friend, my colleague, my mentor, Dr. Kevin Blinder, who will talk to us about photobiomodulation, the good, the bad, and the ugly. Dr. Blinder.
Well, thank you, Brad. And I'd like to thank everyone for attending today. Let's see if we can get this off here. Good. Very good. So my title, Photobiomodulation, the good, the bad, and the ugly. There's a few things. Let's see, we'll go here. A few things that we want to talk about today. I'm a fan of the old spaghetti westerns, Sergio Leone's spaghetti westerns ages ago, prior to my time, actually. Clint Eastwood, Lee Van Cleef, and Eli Wallach, of course. And this correlates to the good. I feel like the Retina Institute, my partners are the good in our field, the best that I know of. Proud to be a part of the Retina Institute and our spring Retina update. Dr. Smith does a wonderful job running this. Thank you, Brad, for doing this. And most of all, I'd like to thank everyone for attending today and certainly supporting our practice, our patients. Without you, of course, we wouldn't be here today. So thank you again. The bad is me trying to play pickleball. I did play for a while, and unfortunately, it led to the ugly of my Achilles tendon rupture. So I don't recommend it for any of you other than play safely. But I still think I have time to rehab and get back in shape and try out for the St. Louis Shock Professional Pickleball Club. So this may appear on a quiz later on if you're part of that. So you may see me playing professionally someday. These are my financial disclosures. So let's talk about treatments right now. We're going to talk about DME and AMD, dry AMD during this discussion. And, you know, we actually have the best answer we've had to date in the anti-VEGF injections, both for diabetic macular edema and for wet age-related macular degeneration. But as you all know, there's many disadvantages to anti-VEGF therapy. We have to bring the patients in very often. This may be a hardship for the patients, for their families. You know, it's just a very difficult thing for them. And if they come in too infrequently, we may lose vision. We may lose the game, unfortunately. There's a risk every time we do an injection, bleeding, detachment, endophthalmitis. The cost sometimes is prohibitive for some patients. We have to take that into account, unfortunately, and there are cases that don't respond to anti-VEGF therapy sometimes. So we're looking for the answer. We're looking for new novel therapies. And so one that's come up is photobiomodulation, which is really treatment with light, different wavelengths of light that have been attempted. This has been in the medical field now for a while. There's been many different fields that have utilized photobiomodulation. Many instances it improves wound healing, reduces apoptosis, reduction in the oxidative stress, many other effects that have been shown in medicine. So there have been some clinical trials looking at the treatment of diabetic macular edema, and that's why we started looking at this. One trial was by Tang, BJO in 2014, looked at a non-randomized consecutive case series evaluating photobiomodulation for non-center involved DME. They had 4 patients, bilateral DME. One eye was treated, one eye served as the control. And it was a treatment of 160 seconds per day for 2 to 9 months, and looked at the thickening on OCT. And what they saw was, you can see here, the treated eyes are here on the left, untreated eyes. Red is bad, of course, on OCT. You can see pre-treatment, post-treatment. On all these cases, pre-post looks better in each case of the treated eyes versus the untreated controlled eyes look the same or worse. So it actually was shown to be effective. And there were a few other smaller trials that looked at this photobiomodulation for DME. There was a Cleopatra trial, a phase 3 clinical trial looking at light at night delivered by sleep masks to prevent progression of diabetic retinopathy and DME. They used a blue-green wavelength monochromatic, 505 nanometers. And of course, you could predict this probably. Compliance was an issue in this one. It showed a negative effect actually in these patients. And the biggest reason was, who wants to sleep at night with a mask that's delivering light all night long? So they had, again, the compliance was very poor in these patients. So we looked for a different wavelength and a different way to deliver this. And this is the mask that was used for Cleopatra. Again, not something that the patients were dying to do. So the DRCR Retina Network, which we're a part of, looked at a pilot trial looking at photobiomodulation to treat DME, protocol AE. And in this, we used a monochromatic light source to evaluate treatment of DME with good vision to begin with, to see if there was a short-term effect, to see ultimately if we should go on to do a larger trial. So this was a phase 2 randomized multi-center clinical trial and involved patients 18 years of age or older, type 1 or 2 diabetes, center-involved DME with good vision to begin with and minimal prior treatment. Some prior treatment, but not a lot. And they were randomized to photobiomodulation versus placebo in 1-to-1 fashion. And we were part of this trial. And we used, again, a delivery device, this photo optics on the right, with only treating one eye at a time in this patient. Only one eye was in the trial. 90 seconds, 2 times a day. So a lot more humane treatment in these patients than the Cleopatra. And again, 670 nanometer wavelength, one wavelength was used in this not a lot of energy was utilized. And the placebo was identical eye device, but it was a white light at a very low threshold, very low power level. So the study follow-up was consisted of visits 1 month, 2 months, 3 months, 4 months, and at 4 months they would switch to the other arm. So treatment was switched to placebo. Placebo was treated to treatment, or switched to treatment, and this is during COVID. And so some of these patients were allowed to continue the treatment arm, and they and not go to the placebo arm if they wanted to. So during this trial, the investigators could provide an alternative treatment for these patients if there was a visual loss defined as greater than or equal to 10 letters at a single visit, or 5 to 9 letters at 2 consecutive visits, at least 21 days apart. The treatment was determined by the investigator, whatever they were comfortable with. And if they were treated in the trial, then they were exited from the trial at 4 months. So we had 135 eyes, 135 participants, randomized 1-to-1 again. Phase 1, 4 months, we had 100% participation. Continued to phase 2. Again, some people dropped out due to COVID reasons, or due to we had a few deaths in the trial as well. These are, again, diabetics that are, unfortunately are prone to other diseases, other morbidities, mortalities. The baseline characteristics, demographics were very similar. I like to think of their age as younger and younger as we get older and older. So diabetic age range, normal, more predominantly males than females, type 2 diabetics. Hemoglobin A1Cs were adequately controlled, not fantastic, and mainly Caucasians. And they did have some prior treatment. Again, they were allowed to have prior treatment in this trial, but not a lot. And their visual acuities were good. Again, we wanted patients had good acuity to begin with moderate DME, as you can see here, and mainly phakic patients. So what happened in these patients? Well, anatomically on the OCTs, they actually increased over 4-month duration in the phase 1. And you can see the clinically involved center involved DME at 4 months was very high in both groups, treatment and placebo. And the OCT volume changes were very similar, both arms, treatment versus placebo. And their mean visual acuity change from baseline was about the same. Actually went down a little in both arms. So anatomically, visually, not a success. Alternative treatments in these patients was low, so they didn't have severe, significant changes for the worse. Not positive changes either. Compliance was very good in these patients. Time between use was what you would think for a PID dosing. And issues retrieving the compliance data from devices was pretty low. So compliance by month was, again, very good overall. This is something that patients were dying to do. You know, if you present to them, do you want a light treatment to your eyes, or do you want a needle in the eye? Patients were very willing to be involved in this trial. So we had no problems recruiting. Was there association between anatomic changes and compliance? And there really wasn't. And the devices overall functioned pretty well. And in terms of going on to receive a device from treatment to placebo, again, many patients opted out of the placebo second phase due to the COVID amendment. And again, the devices overall were fairly durable. Some had to be replaced, which is not unusual. Adverse effects were really minimal. You know, some patients had some photophobia, some color vision changes, but overall, I think that this was well tolerated. But again, overall, the conclusions of this trial, protocol AE for photobiomodulation for DME in these patients was not effective, unfortunately. And we didn't go on to support a phase 3 trial through the DRCR network. So the conclusion was we need something else. This is not what we wanted the result to be. And we thought, well, at this point, photobiomodulation may not be an option for DME. But there may be other options also. So Lumathera came along and they came up with a Valida light delivery system. And this has been something that's been very exciting data. So their thinking is, well, maybe it's not a monochromatic treatment that you need. Maybe it's multiple wavelengths. So they came up with through laboratory work 3 different wavelengths to deliver for their photobiomodulation treatment. And here it's just showing that in rat models with methanol toxicity, you can actually prevent the methanol toxicity of the retina in a rat model via photobiomodulation. Here's showing again some preclinical data in non-human primates, laser effects on the left with no photobiomodulation, and laser effects on the right. You can see that it doesn't lead to as much scarring, not as much damage if you have a concurrent photobiomodulation treatment. So just some preclinical data supporting their clinical trials. This is the Valida light delivery system, pretty lightweight, pretty small platform. And you can see the wavelengths about 590, 660, and 850 nanometers. And there's different reasons for that, which we will get into. Again, the multi-wavelength, non-invasive, takes less than 5 minutes, 4.5 minutes per eye, no pupillary dilation. It's 9 flexible sessions over 3 to 4 weeks, 3 times a year. So this was, most trials looked at every 4 months, with 9 sessions every 3 to 4 weeks, or during the 3 to 4 week duration, and 2 to 3 treatments again per year. And we looked at 3 treatments per year. The primary photoreceptor is the mitochondrial cytochrome C oxidase. Keep that in mind. So we were asked to be part of the upcoming trial, and due to our experience with protocol AE, we actually opted out of this, which I wish in retrospect that we hadn't. So they did many trials beginning in Europe, and now in Europe, this is a approved treatment for dry macular degeneration. So mitochondrial dysfunction involves different disease entities throughout the body. In the eye, there's other things that it affects other than AMD, DME, glaucoma, hereditary retinal diseases as well. The ultimate role here is cell death and blindness. Very detailed diagram showing the results of mitochondrial dysfunction. But what it is it's the cytochrome C oxidase, which is actually in the mule glia cells that we're trying to accept the light treatment, the photobiomodulation, to do different things in the eye. So the photons are absorbed by this photoreceptor, cytochrome C oxidase, and there's secondary effects that occur with increases in energy production, improved blood flow, reduced inflammation, with the changes in signaling modalities. And again, each wavelength was chosen for different reasons. But in combination, it seems to produce the effect that, again, that we want to see. So there's been different trials, 5 successful clinical trials, over 200, about 200 patients across different trials. approved in Europe again that we talked about. And the US LightSight 3 trial is really the trial that we did here in the US, phase 2, and then just phase 3. The 24-month data was just recently released, and I actually have that here to show you. So this is a pivotal trial. We looked at 13-month and then at 24-month results. And again, 24 months was just released the other day. So many of our colleagues were part of this. So I think a reputable group of investigators. And this was a 2-to-1 randomization of photobiomodulation to active sham. I say active sham because there's still some light treatment in these patients, but it was at a reduced dose, greatly reduced from what the treatment was. And every 4 months, they had 9 treatment sessions within 3 to 5 weeks, out to 24 months. So the results visually, looking at 13 months to begin with, and then at 24 months, they had a mean change, 13 months at 5.5 letter gain in treatment versus sham, and a 5.9 letter gain by 24 months. So really a significant visual improvement over time by 24 months. And so, again, looking at the 13-month data versus the 24-month data, it's interesting. The treat arms, again, photobiomodulation did well, but also the sham arm did well because they were still receiving some treatment. 13 months a little better than 24 months. And then there was the uncontrolled or no treatment at all control group, which I think was about 12 eyes, that actually had a decrease in vision at 13 months. So this is the arm that actually had no treatment whatsoever. So showing those eyes that had greater than or equal to 5-letter gain, again, more in the treatment arm versus the sham, greater than or equal to 10 letters, and then greater than or equal to 15 letters was 5.5% of the treatment arm. So again, significant gainers in the treatment arm. How about the new onset of geographic atrophy? Something we hate to see in any patient that we're treating. Again, these are moderate dry AMD patients to begin with, and progression to GA was not a good result, obviously. So in the sham arm, at 13 months and 24 months, they had a significant amount of patients that actually went on to develop GA. In the treatment arm, a much lower percentage, which was, again, significant. So the LightSight 3 summary showed it to be effective treatment for dry AMD, intermediate dry AMD to begin with, showed visual gainers, reduced amount of patients that went on to develop GA. And I'm going to show you also some cases where it showed a reduction in the drusen volume as well. So certainly positive, a much more positive result than we saw with the treatment of DME in the DRCR group. Again, there's been many clinical trials looking at photobiomodulation with the Veleda light source delivery system. So here's one that looked at a combination of utilizing ERG data in the photobiomodulation. Done here in the US, there was 8 males, 7 females, 100% Caucasian, mean age of 75.1 years, and mean time since diagnosis was 5 years. So their outcome was 14% increase in multi-luminance ERG function. Again, ERG data, this is objective data, which was a positive result. They had a 12.4 best corrected visual acuity letter improvement, significant amount of vision improvement. Mars contrast sensitivity was improved at all 3 distances, OCT reductions in select patients, and no significant side effects. So with the ERG data as well, showing a good result. Again, many different trials. The overall gist of this is that they all had visual gains in their results. And here's just showing in the LightSight 1 dry AMD trial. You can see here on the left that there was actually a reduction pre-treatment, post-treatment of drusen, and a reduction in the PED as well. So briefly, for diabetic macular edema, to show some results here again. For the monochromatic treatment, didn't show a result for a wavelength treatment. I think there are more positive results in vision. The control group went down versus the treatment arm actually went up in the treatment arm. And then anatomically, control group thickened over time versus the treatment group actually decreased thickness over time. This is the delayed first patient treated with center valve DME. You can see on the left eye, you can see the cystic change that went down over time. Right eye, even more impressive reduction. And then ARVO 2021, Becker and co-authors presented a group of patients, 28 eyes of 18 diabetic macular edema patients that underwent photobiomodulation treatment. There was a 28.6% reduction in intraretinal fluid, 40% reduction in hard exudates, slight reduction of central retinal thickness, and then stable vision, but subjective improvement of vision and daily functioning. So again, positive results for the multi-wavelength treatment. So I think that this is something that the bad part of this was that monochromatic mono wavelength treatment for DME did not show a significant difference in treatment, but the multi-wavelength did show a difference for dry AMD as well as for diabetic macular edema. So I think it's something that's going to come to be. It's in the process of FDA approval, and I think we'll hear more of this in the future. So thank you very much. I'm open to questions.
Kevin, thank you for that review of photobiomodulation. Very interesting data. Hopefully it will come to fruition as being able to use it for our patients. As you stated, yes, the injection is weighing heavy on doctors, families who transport their patients or their friends to get the injections, and the healthcare system at large. So it'd be nice to have an alternative therapy. One of our cases, if I would encourage all the attendees to stick around, one of our cases at the very end is going to feature a particular case that highlights the unification of diabetes and geographic atrophy. So I'm interested to hear your comments on that when we get to it, Dr. Weiner. Any questions? We have one from one of our attendees. So given the light sight results, what advice might you give regarding advice to AMD patients to wear sunglasses, UV blocking or otherwise?
Well, I think that's a different wavelength now. So I think we do want to have these patients wear UV blockers. But, you know, and again, this is 3 specific wavelengths that was therapeutic. So I don't think we want to expose them to unnecessarily to other wavelengths. So I still believe in UV blockers at this point.
I know a lot of our friends attending today probably get many questions per day, and we do as well as retina specialists about whether or not patients should purchase blue blockers when using screens. What, do you have an opinion on that, given your study of this information?
Yeah, you know, I haven't gone either way on that. I know there's some data out there that says if you're on screens a lot, which I think presently, we are on it a lot more than we should be, and our kids are on it even more. So it probably doesn't hurt. At the same time, I haven't seen great data out there yet, but I think we should use caution and certainly recommend it for those that are using it quite a lot of screens.
There were blue light blocking IOLs in the past, probably 15 or 20 years ago, and they found out that these IOLs will actually disturb the circadian rhythm because the blue light has to do with the melatonin secretion. So then they stopped doing them. But yeah, I agree with Kevin, the data are not really robust to suggest that we should wear blue light blocking filters.
It is interesting though, the old data, Thomas, if you remember, the blue-green wavelength lasers. If you remember that, the data came out that it was actually harming the the physicians that were using the lasers. So that's the reason why we transitioned from blue-green to green, because they thought the blue part was actually leading to decreased contrast sensitivity, and the retina specialists and ophthalmologists using it. So yeah, so that's why I can still see, because we got rid of that blue, for the blue-green wavelength.
Now, there's a question about cost and insurance coverages for these new treatments. I assume none of these are commercially available, but if you could speak to that.
Right. So right now it's available in Europe. I have no idea what the cost is presently, but they are submitting now, since the LightSight 3 data is 24-month data is in. They are submitting for FDA approval, and this is something that's an in-office procedure. I know we've talked about home devices. The DRCR photobiomodulation treatment was a home use device. That's why we're so excited about it. But it obviously didn't work. So this is an in-office procedure that I think will have certainly implications for patient flow, patient volume. We have a home OCT unit that we're trying out now that's up for FDA approval as well. You know, so maybe someday the Lumathera will produce a home photobiomodulation device as well. I think it'd be easier for patients.
Excellent. Okay, well, we don't have any other questions. Let's move on to our next talk, given by Dr. Thanos Papakostas. This is going to be on a critical review of complement inhibitors.
Thank you very much, Brad. Good morning to everyone. Welcome to our spring update. I'm really proud and honored to be associated with one of the best groups in the country. We're at the forefront of clinical trials, as Kevin mentioned before, and we want to offer all the up-to-date treatments for our patients. So my topic today is going to revolve around something that is quite hot right now. Many patients are coming to our offices and they're asking about new treatments for dry AMD, and namely geographic atrophy, and many of you are actually asking us questions. Should we use these drugs or should we not use them? What are the data out there? So I'm going to present the critical review of complement inhibitors in geographic atrophy. So the complement story in GA started almost 20 years ago, when we started unraveling the genetics of geographic atrophy. And the seminal finding was that investigators discovered single nucleotide polymorphisms in complement factor H. Then additional studies were done after this seminal finding over the years that showed complement 2, 3, 9, CF5, CFB, and CFD, but not C5, which is a target of one of the drugs currently under investigation, are associated with geographic atrophy. So in terms of therapies targeting GA, why do we want to target GA? Why not, for example, early dry AMD? Preventing GA offers endpoints and timeline more amenable to clinical trial design than preventing progression of earlier stage macular degeneration. The idea here is to prevent progression of non-central GA to central GA, which will lead to vision loss, and eventually also treat the atrophy that occurs when neovascular AMD is controlled. We do know that repeated anti-VEGF injections over the years carry high risk of conversion to geographic atrophy in these patients. It's about 50%. And of course, improve long-term vision outcomes in neovascular AMD. So this is the timeline of complement inhibitor trials for GA. As you can see, it's a busy slide because we've been very busy over the last, I would say, 5 to 10 years trying to come up with something that can help these patients, because this is the greatest unmet need right now in our field. This is essentially the holy grail in our field. Whoever finds a treatment for dry AMD and geographic atrophy, that's going to be a game changer. So we've invested a lot of time, a lot of money over the last 10 years to find something that works. And as you can see, there's a program by Apellis. This is the first FDA-approved treatment, pegcetacoplan. There is a program by Iveric Bio. It targets C5. It's under investigation, but likely it will be approved in the summer. And then there were other trials in the past that failed. There was a trial by Genentech targeting complement factor D via monoclonal antibody, lampalizumab, which failed. And then complement factor H, there was a trial that was done a few years ago. It was stopped because there were no positive results. And then other trials that are currently under investigation. So in contrast to our prior successes in wet AMD, now we get mixed results with the trials for complement inhibition. In wet AMD, we had great results. All the agents that we've tested in the past, and they were approved by the FDA, they were leading to either improvement in the vision or preservation of the vision. But here the results are quite mixed. For example, the lampalizumab trial failed, and it was the warning signs. You could also see them from the phase 2 trial, where the statistical significance level that they observed was quite high, and because there was a subgroup analysis that showed that patients with a certain genotype will behave differently, then they proceeded to the phase 3 trial, which, as we know, failed. Now, C5 inhibition was trialed before by Novartis with a monoclonal antibody, and it failed. And now we have two trials that show mixed results. We have the trial from Apellis and the trial from Iveric Bio. They both met their primary endpoint. However, there's no functional benefit, and there is a high rate of discontinuation or dropout, which creates many concerns amongst doctors. So why isn't the genetics and biology supporting it? As we can see here, all these trials were based on genetic data. Unfortunately, we don't have an animal model for geographic atrophy to test all these compounds before we go to humans. So essentially, we're going from genetic data to human trials. And if you see here on this table, this is a summary of all the risk alleles for AMD. The ones that are associated with GA growth are ARMS2 and the apoprotective allele. C3, depending on which cohort you're looking at, might actually be protective. And C5 was never associated with GA growth. And the reason for that is that genetics show susceptibility to AMD that is not equal to progression of geographic atrophy. In other words, if you study in a certain cohort of people a SNP that confers susceptibility to heart attacks, that doesn't mean that everybody in this cohort will develop a heart attack. Genetics do not translate to causality. They can give you some suggestions, they can give you hints, but they do not translate to causality. However, the Apellis C3 inhibitor announced positive phase 3 results, and the same case was for the Iveric trial. Well, let's have a closer look. As we all know, there are lies and there are statistics. That's something that is well known in the history of biostatistics. And a common problem in trials is when you start cherry picking your results, which is nicely shown in this graph. Cherry picking is essentially avoiding data that do not support your hypothesis and focusing only on the data that support your hypothesis. So based on the study design, there was perhaps an overestimation of the treatment effect. These are all the trials tabulated. The Philly C3 trial, which was the phase 2 by Apellis, and I'm showing the dropout rates. In the sum, it was 15%, in the every other month, 24%, and in the every month, 40% dropout rate. In the Derby, which is the phase 3 of Apellis, the dropout rate ranges from 20 to 30%. The Oaks, the same, and the Gather, which is the Iveric program, again, dropout rate from 11 to 30%. And these patients were included in the final analysis. And as a reminder, when we go back to the complement factor D trial, the lampalizumab trial by Genentech that was done 10 years ago, in the phase 2 with high dropout rates, there was seen a positive effect. It was about 25%. And then when they went to the phase 3 and the dropout rates actually became much lower, equal amongst all the treatment groups, there was no effect at all. The other problem is the conversion to neovascular AMD. With the C3 inhibitor, there is a high rate of conversion to wet AMD in the FILLY trial, which was the phase 2. It was about 20% on the every month arm. And in the Derby and Oaks trials, which were the phase 3, the ones that led to the approval of the medicine, the conversion to wet AMD was about 12% in the monthly arm and 7% in the every other month arm. The conversion to wet AMD in the sham arm, in the observation arm, meaning no treatment, it was consistent with historical reports, low single digits, 3%. And similar rates were observed also in the Gather trials, the Iveric program targeting C5. When we look at the primary endpoint that was met by the trials and that led to the approval of the medicine, which is essentially the GA growth, the growth of the GA lesion. When you look at the phase 3 trials, one of the trials failed. It didn't show any difference. The Derby trial, it failed. The p-values, as you can see, they're quite high, which shows that there is no difference at all. While they did see a difference in the Oaks trial. And then when you look at 2-year data of the Derby and Oaks, you do see greater differences that led to the approval of the drug. However, if you read the small print in the presentation of the company, the least square means were estimated from a mixed effects model for repeated measures analysis. So basically, they developed a statistical model to compensate for missing values in their dataset. As we said before, there was a high dropout rate in all these trials, so they had to compensate for missing values in order to include all these patients. So the nominal p-value is a calculated observed significance based on a given statistical model. And the model assumes values missing at random time points. So the questions that need to be answered, and we haven't had an answer yet, what are the baseline characteristics of those that dropped out versus the ones that completed the whole study? And what are the baseline characteristics of those that converted to wet AMD versus the ones that did not convert to wet AMD? What are the GA measurements at baseline, at conversion, and post-conversion for those that converted to wet AMD? So we really don't have an idea what happened with these patients that converted to wet AMD. How much vision they lost? Did they lose vision? Were they able to regain their vision? We do not know at this point. So the statistical methods also for validating assumption of missing at random were not presented. And the actual measurements of GA or square roots were not shown. But for the sake of the argument here, let's make a hypothesis and let's assume that it does decrease the GA growth rate. So how much is that in an actual macula? So I'm showing here a graphic with sham and monthly injections, and we're going to overlap the growth of the lesions. So the control is the orange circle, and the drug is the green circle. So this is how the lesion looks at 2 years. And if you're taking the drug, this is how the lesion will look at 2 years. So when you overlap the control versus the treatment, that's what you get. So very small difference. It's quite hard actually to decide from this schematic if there's any difference at all. So does that correlate with any functional or patient-perceived benefit, or we're just treating a test here? We're essentially treating a surrogate marker. This is the press report from Apellis last summer, consistent with expectations, no clinically meaningful difference on key functional endpoints observed at 24 months. So contrast sensitivity was not evaluated, dark adaptation was not evaluated. There was no difference in low luminance best corrected visual acuity. There was no difference in low luminance deficit, no difference in reading speed, no difference in the functional reading independence index, no difference in the National Eye Institute VFQ 25 score. And in terms of the overall vision drop, the patients that were in the sham group lost 7 letters, in the monthly group 8 letters, in the every other month 9 letters. So pretty much everybody that was on this trial lost vision, and they lost vision at the same rate. But what about its risks? If you look at the risks, you can get, as we said, conversion to wet AMD. In the every month arm, it's about 4x compared to the every other month, which is 2x. In the every month arm, you can get ischemic optic neuropathy. It's about 1% the risk. Inflammation, 20 times higher than the sham in the every month arm, and 10 times higher in the every other month arm. And no functional benefit at all, no way you look at the data, as we said before. So what is proven about complement inhibition so far? It's proven to increase conversion to wet AMD, so it can worsen your VA, your visual acuity, despite anti-VEGF treatment. It's proven to increase inflammation, infection, and optic neuropathy, and it's proven not to improve any function based on multiple functional tests that were evaluated on the trial. The surrogate endpoint that we're measuring in this trial, which is the rate of the GA growth, is essentially a statistical model based on the analysis that we mentioned before. And if you look at the overlapping circles here, the control versus the treated arm, the radius of this benefit that you get over 2 years equates to the size, to the surface size of a few RPE cells. So as you can tell, the effect is quite minimal. So the biology, genetics, they do not support the role of complement inhibition in GA growth. You get a minuscule benefit in a test metric that uses statistical model that overestimates effects. And then you have unequivocal studies proving increased serious risks without improvement in any function. We all took an oath, first do no harm. And many people have arguments and say, well, if the patient can keep vision good enough to drive longer, then it's worth getting the injections. Of course, you know, when you use this argument, you fail to remember that you have to do a critical evaluation of the data. And so far, based on the evaluation of the data, there's no functional benefit. The other argument is, what if you don't see a benefit at 2 years, but if you do the injections long enough, for example, 3, 4, 5 years, maybe you can see a benefit there. This hasn't been proven yet, so it will be good to see the 3, 4, or 5 year data and then make a decision. And the other argument is we should approve because we have nothing. and that ignores safety and lack of efficacy. So this is what I mentioned before. That's a common argument in favor of the treatment. There's no functional benefit at 2 years, but if you do it long enough, 5 years, you will see an effect. So this is how 5 years of treatment will look. It's going to be a significant burden to the patient, both treatment burden and financial burden to the patient and their families. And if this is true, let's see the 5-year data in terms of efficacy and safety, and then have a discussion then. And as a reminder, the effect on the GA growth may be compounded over time if real, and the same applies for the side effects. So the more you treat, the higher the risk to observe the side effects that we mentioned before. So why are we getting negative and mixed results after all these years of investigating complement inhibition and geographic atrophy? This is a paper that was published just a few days ago in Ophthalmology Science. So it's a post-hoc analysis from the lampalizumab trial, the genetic trial against complement factor D that happened 10 years ago. So what they did is they were collecting IQ samples from patients on the trial, patients that were both on the treatment arm and the control arm, and they were following these patients over time, and they were evaluating complement activity levels in these IQ samples. The conclusion of the study was that complement levels or activities in aqueous humor and plasma did not correlate with GA lesion size or growth rate. And the investigators suggested that local complement activation, as measured in aqueous humor, does not appear to be related to the GA lesion progression. So the other problem we see is that usually in drug testing, you have a hypothesis based on genetics, then you do trials in animals, and then you proceed with trials in humans. Unfortunately, here there's a lack of animal model for geographic atrophy. And that's why we go straight from genetic data that sometimes can be conflicting to human trials. So in summary, there's lack of functional efficacy with complement inhibition for GA. The risks are real and might lead to irreversible vision loss. And better understanding of the biology of the disease is needed in order to develop new effective treatments. Thank you so much.
That's wonderful. An eye-opener. What do you guys think about this treatment?
Thanos, I thought that was an excellent talk and very timely. And it's a challenge for us. The patients are desperate, providers are desperate to treat this, as you mentioned, and then it's on the news and it's in the journals and magazines that patients have, and we get bombarded with these questions where the data, as you mentioned, just doesn't, in my mind, support putting patients through this. And it's a hard thing to combat the media that's pressing us to do this. And that excellent review, and I think appropriately brings up many of the cautions, or all the cautions that we should have in mind when we think about using this for our patients.
Thanos, you've shaken my faith in the FDA. Following their approval, is Medicare obligated to reimburse this?
Medicare is not obligated to reimburse this. It's CMS that makes a different decision. Usually they do reimburse. The only example that I can think of that they did not reimburse an FDA-approved treatment was a couple of years ago with the Alzheimer drug by Biogen, Aduhelm, where the FDA approved it, but there were many people that doubted its efficacy, and then eventually CMS did not reimburse it, mainly because of the extremely high cost of the treatment. But yes, CMS is not obligated, but most likely will reimburse it.
Thanos, do you think, again, great talk, great summary. Do you think that the FDA felt pressured to prove it because it's the first treatment out for geographic atrophy?
I think so. I think the lack of any other treatment for these patients probably exerted a lot of pressure on the FDA to approve it. I think that's what we're dealing with now.
But CMS has no obligation to approve a certain price? Doesn't the manufacturer choose their own price and then CMS either thumbs up or thumbs down in reimbursement?
Yes, that's how it usually goes, yeah.
Dr. Ife, I was wondering if you could share your experiences out on the West Coast. What are the feelings about this new drug?
So we had a speaker just yesterday at a conference that's being hosted at UCLA by Rick Spade, who spoke and had very similar concerns that Thanos is sharing here today. We definitely hear a lot of patients asking about it, but as far as I know, all the providers here at UCLA are all quite hesitant about offering it to patients. I think there are some select scenarios where if someone lost central vision in one eye and have parafoveal GA in the other, maybe they would consider it in those patients just to try to preserve the retained central vision. So I think there are some select scenarios where it might be interesting or might be worth having that discussion with patients and potentially offer. But on the whole, there isn't a large amount of excitement out here either.
Yeah. So it's unfortunate. Maybe this will be history repeating itself, similar to the Macogen story over a decade ago or 20 years ago, where it's a start, but hopefully it'll lead to much better treatment going forward. All right, well, we're a little ahead of schedule, which is great. Let's go on to our next speaker, and that is Dr. Ife, who we're pleased to say he will be joining us this fall as a new associate. He's going to be speaking on the topic of AI and retinal imaging.
Thank you, Dr. Smith. Hello, everyone, and good morning. I'm Dr. Nicholas Ife, a senior vitreoretinal surgery fellow at the Jules Stein, UCLA. This fall, I will be joining the Retina Institute as an associate retina specialist and look forward to meeting and working with many of you. It is my pleasure today to present on a topic that I find quite interesting: innovations in retinal imaging and artificial intelligence. Here are my financial disclosures. Now, whenever I think about innovation, I always find it amazing to look back at its basis in history, in particular here with ophthalmoscopy. In 1851, Hermann von Helmholtz, a German physicist and physician, was credited with creating the first direct ophthalmoscope. This device incorporated three key elements: a source of illumination, a method of reflecting the light rays into the eye, and an optical means of correcting an out-of-focus image of the fundus. And here you see one of the original designs with Dr. Helmholtz's name on the lens case. 1 year later, in 1852, Christian Georg Theodor Ruy, a German ophthalmologist and strabismologist, modified von Helmholtz's design to create the indirect ophthalmoscope. This design incorporated concave mirror that reflected light into the eye and use of a 13 to 20 diopter lens to make a real inverted image. This provided less magnification of the retina, but a wider field of view. Roughly 10 years later, a French ophthalmologist by the name of Marc-Antoine Giraud-Tallon further built upon both designs by creating a handheld, binocular, indirect ophthalmoscope. This combined rhomboid prisms in a metal carrier with perforated concave mirror. It did provide stereopsis. However, the interpupillary distance was fixed, making this somewhat cumbersome that it had to be customized to each examiner. Binocular indirect ophthalmoscopy was largely abandoned toward the end of the 19th century in favor of direct ophthalmoscopy, until it was revived in the 1950s. Nearly a decade later, Belgian ophthalmologist Charles Schepens in 1947, who is credited as the father of modern retinal surgery, revolutionized the field by creating the hands-free binocular indirect ophthalmoscope, which had a built-in light source, allowing the physician to hold a lens and a scleral depressor, thereby facilitating view of the retinal periphery. And here you see a schematic which is not terribly different from what we are used to using today. Prior to ophthalmoscopy, the cause of rhegmatogenous retinal detachment was unknown, and the treatment was largely unsuccessful. Once physicians were able to see the retina, the challenge became examining the retina for 360 degrees to identify all retinal breaks. Once the breaks were located, the question became, how does one devise a plan to address the detachment surgically? There became a need to determine areas on the surface of the eye to treat the intraocular pathology. The preoperative planning was done with both direct and indirect ophthalmoscopy, but was often cumbersome and time-consuming. Here is a device that was used preoperatively to measure out the locations in degrees and about which meridians the retinal breaks were located. As you can see, this takes quite a bit of coordination and patient cooperation, and just imagine trying to reproduce this in the operating room. It was quite the feat, but allowed physicians to be able to fix retinal detachments at the time. Prior to vitrectomy, scleral buckling was the primary way to close retinal breaks and fix retinal detachments. Combined with diathermy, cryopexy, laser retinopexy to form adhesions around the break, and an intraocular tamponade to keep the breaks closed. And although this talk isn't focused on retinal surgery, we will return to surgical innovations at the end of this presentation. So that brings us to the current way of evaluating the retina. As you are all familiar with the modern slit lamp and indirect ophthalmoscope, there have been and will likely remain the most important instruments in our in-person clinical evaluation. However, further innovations in retinal imaging are likely to change the way in which we evaluate and treat patients. Currently, we use many camera and imaging devices to document and track both external and intraocular findings. These tools include the tabletop and handheld fundus cameras, wide field and ultra wide field fundus cameras, OCT, and fluorescein angiography, all of which facilitate diagnosis and treatment of ocular pathology. Recent advances in retinal imaging have led to faster and easier acquisition of diagnostic data and the ability to quantitatively follow change over time. One advancement in the last decade that I have found most interesting is the development of OCT angiography. For those of you who are unfamiliar, OCT angiography, or OCTA, builds upon the foundation of OCT and produces an image of the retinal vasculature without the need for intravenous dye injection. OCTA technology detects motion and can extract and amplify the phase or amplitude component of motion and compare that to static tissue, thereby inferring where the vasculature resides. Structural OCT uses interferometry to differentiate the many static layers of the retina and creates an en face, depth-resolved platform with which to view the image. Here, as an explanation for OCTA, I want you to imagine the faucet on the left image has a continuous running water stream. If you were to take several images from the same location and analyze just those areas in the picture that are changing or moving, one could detect flow by way of this motion contrast. This is depicted in the image on the right, where only the running water is highlighted. Building upon that idea, by taking multiple OCTs in the same location of the retina and comparing the images, a computer can detect where the red blood cells are moving within the vasculature. Furthermore, the software allows one to scan through the image of the volume of the image, similar to scrolling through an MRI or OCT, and allows one to look at the vasculature of different layers within the retina. For the first time outside of histologic slides, we have been able to visualize the trilaminar plexus of the macula, which is made up of the superficial, deep, and intermediate capillary plexuses. Traditional fluorescein angiography poorly identifies the two deeper vascular plexuses. By visualizing the deep plexus, we are now able to make inferences about disease processes that primarily affect this area of the vasculature. And one of my mentors here at UCLA, Dr. Saraf, has defined this finding as paracentral acute middle maculopathy, whereby there's ischemia in particular of the deep capillary plexus. Here you can see the vasculature of the deep plexus is more dense and has a finer caliber vessel than its superficial counterpart. The outer retina image is dark as there are no intrinsic retinal vessels in this area of the retina. The chorea capillaris is made up of fine, fenestrated capillary network and still remains difficult to image with current OCTA devices, although future advancements and refinements in the technology will likely enable better visualization of the choriocapillaris. Here is a case of a 21-year-old healthy female who presented with acute vision loss in the left eye. Her multimodal imaging, including fundus photography and fluorescein angiography, was unremarkable. However, her OCT showed a hyperreflective PAM lesion in the macula, which definitely is abnormal for a 21-year-old. Structural en face OCT of the middle layers of the retina, here in the middle picture, demonstrated paracentral acute middle maculopathy or PAM lesions in a perivenular fern-like pattern, which led to the diagnosis of central retinal vein occlusion and appropriate workup, including labs for hypercoagulability in this 21-year-old female, were undertaken. Patterns of findings like these seen in en face OCT can help make diagnoses when older imaging modalities are normal in appearance. The ability of OCTA to show vasculature across varying depths of the retina also enables it to reveal choroidal neovascular membranes associated with exudative age-related macular degeneration. Furthermore, data analyses of these images can provide qualitative and quantitative measures to monitor changes over time. Here's an example of a patient with exudative AMD. I am sure you are all familiar with the bottom OCT, showing a fibrovascular pigment epithelial detachment associated with subretinal fluid, indicating the presence of a CNV and the likely need for treatment. The images on the top are the OCTA images in two different sizes, where one can actually see the neovascular complex. Image processing allows one to highlight the vascular complex, here seen in purple, and measure its size or area under the retina. It also allows one to produce a skeletonized image, which can be used to measure vascular density within the membrane. While these metrics are not currently used to aid in our treatment algorithms, having an objective way to track responses to treatment may prove to be beneficial over time. So quickly to summarize and compare FA and OCTA, FA does require a dye injection. It produces dynamic images, but no depth resolution. It's somewhat invasive and can take upwards of 50 to 20 minutes to achieve. As opposed to OCTA, where it requires no dye injections, it does provide static images, but there is depth resolution to the volume that's created. It's non-invasive and relatively short, where the images are required in less than a minute. Of course, there are some disadvantages to any new technologies, and with regard to OCTA, those include that new artifacts are being identified, and when new artifacts are identified, we need to attempt to reduce them in the imaging. Media opacities, such as cataracts or even dry eyes, can greatly reduce image quality. Another disadvantage is the need to ensure that the retinal layer segmenting of the image is correct, which is problematic to adjust with current software. And the need for reasonable central visual acuity and steady fixation of the patient in order to obtain repeated scans in the same location of the retina. Another advancement in retinal imaging is the ability to obtain an OCT outside of the area of the macula. Highly trained imaging technicians can currently obtain OCTs outside of the macula by having the patient fixate eccentrically or moving the camera off of the visual axis. This can aid in the diagnosis and clinical decision-making for treatment of retinal pathologies such as retinal breaks, vitreoretinal tufts, retinal schisis, retinal detachments, and could inform the urgency with which a referral needs to be made. Here is a commercially available camera that can easily obtain OCTs of peripheral areas of the retina, as seen in the ultra-wide field image to the left. From what I am told, it is as easy as point and click, and most technicians produce high-quality scans with little training. You can imagine how helpful this would be to see an area of the retina that looks different or concerning on exam to determine if it has any true findings or pathology of the retina on OCT. An example of informing the urgency with which to make a referral: the above image is of a patient with a dome-shaped elevation of the infratemporal retina that is concerning for retinal detachment. However, the OCT through this area shows splitting of the retina with the outer retina attached, making the diagnosis most likely retinoschisis. Knowing this is not a retinal detachment can alleviate a lot of worry for the patient while they await follow-up with a retina specialist. The bottom image looks very similar, with the dome-shaped elevation of the retina and the infratemporal quadrant. However, the OCT does in fact reveal retinal detachment, and therefore a more expedited referral would be warranted. International Wide Field Imaging Study Group of retinal specialists with extensive experience in imaging convened in early 2018 to harmonize the terms regarding these images. They reported that the following terms should be used to describe retinal imaging of all types, including fundus photos, OCT, and OCTA. Wide field should be used to indicate a single capture image, capturing retinal anatomy beyond the posterior pole, but posterior to the vortex ampulla in all four quadrants. Here, this area is represented by the area of the retina within the blue circle on the image of the right. Ultra-wide field is a single capture image, capturing retinal anatomy anterior to the vortex vein ampulla in all four quadrants. So the image to the right is in fact an ultra-wide field image. And pan-retinal is a single capture image which captures the entire retina from aura to aura. Currently, there are no commercial devices that I'm aware of that are creating pan-retinal images. Which leads us to artificial intelligence and ophthalmology. I believe that deep learning, principally focused on fundus photographs and OCTs, will ultimately enable improved evaluation techniques to be developed for diabetic retinopathy, glaucoma, AMD, retinopathy of prematurity, and as I will show you here, cardiovascular risk factors, such as age, blood pressure, BMI, and smoking status. Screening for diabetic retinopathy and retinopathy of prematurity will likely be more widely adopted first, since well-established guidelines already exist. AI's role in glaucoma and AMD, however, remains unclear. AI could be used for either screening for these diseases, or it could be used to enhance our ability to detect change within the disease state over time. Deep learning, coupled with telemedicine, could enable screening and monitoring of numerous chronic conditions in the primary eye care setting, and possibly, if done well enough, could extend to the primary care physician's office as well. IDXDR was granted the FDA de novo classification on January 12, 2018, for its ability to automatically detect more than mild diabetic retinopathy in adults diagnosed with diabetes who had not previously been diagnosed with diabetic retinopathy. The platform requires 2 images to be obtained per dilated eye, which are then uploaded via secure internet connection, where they are analyzed, and the initial analysis of the images determines if the image quality is sufficient to provide an assessment. If yes, the program returns an answer as to whether or not the presence of more than mild diabetic retinopathy exists. If no, feedback is automatically provided to the technician to help the operator acquire higher quality images and successfully obtain a result after resubmission of images. This really set the stage for other companies to refine this technique and the use of AI in the medical field. In August 2020, iArt became the first FDA-cleared artificial intelligence technology in medicine for autonomous detection of both more than mild diabetic retinopathy and vision-threatening diabetic retinopathy. It was designed for use with 2 non-mydriatic fundus cameras, though they are hoping to expand to work with other cameras as well. It requires submission of 2 images per undilated eye and provides results in under 60 seconds. Their algorithms are quite robust and boast a very high sensitivity and specificity, and they state that novice operators with limited training were able to capture images in which 97% of the images were gradable. This is quite impressive and seems simple enough to put in a family medicine doctor's office. Now, the final part of this talk is what I find most fascinating, which is the ability of artificial intelligence to accomplish tasks that are impossible for humans. Identifying and quantifying associations in medical imaging is difficult because of the varying features, patterns, colors, values, and shapes in real-world data. Real-world data is often quite dirty. AI is better equipped to process large amounts of information while considering all the subtleties at the same time. It can decrease the need to manually enter patient demographics and characteristics into risk calculators, since the computer program could pull this data directly from the patient's chart. Also, artificial intelligence is better able to create inferences from incomplete data. So, gone are the days where one missing value eliminates your ability to use a given risk calculator. In 2018, the Google Research Group published a groundbreaking paper which showed just how powerful deep learning and image processing can be. Using deep learning models trained on data from over 280,000 patients and validated on 2 large independent datasets, they predicted cardiovascular risk factors not previously thought to be present or quantifiable from retinal images, such as age, gender, smoking status, systolic blood pressure, and the presence of major adverse cardiac events. I really want to emphasize this point. Their model was able to predict these factors from a single retinal image. This is absolutely amazing to me, but something we all intrinsically know to be true, since the eye truly is a representation of a patient's overall health. The top image is a sample retinal image in color from the UK Biobank dataset that this program was run on. The remaining images show the same retinal image, but in black and white. The soft attention heat map for each prediction is overlaid in the image in green, indicating the areas of the heat map that the neural network is using to make the prediction for each given image. Please take a look at each of the actual and predicted values and see just how close the model was able to predict a patient's age, gender, systolic and diastolic blood pressure, and A1C just by looking at a single fundus photo. This paper provided evidence that deep learning may uncover additional signs in retinal images that will allow for better cardiovascular risk stratification. In the near future, a single image of the retina may be more meaningful than a panel of blood tests. By leveraging the existing infrastructure used to screen for diabetic eye disease with platforms such as IDXDR and iArt, cardiovascular assessment at the population level may drastically change. And finally, when will robots replace retinal surgeons in the operating room? While it's unlikely that robots will fully replace humans in the near future, there are already numerous AI-assisted platforms in development which fall into three main categories: handheld smart tools, co-manipulation programs where the surgeon and a simulated system work together to control the tools, and fully automated systems in which the robot controls all of the surgical tools with an overseeing surgeon. Here are several handheld smart tools which have been developed to minimize hand tremor during retinal surgery. As surgery involving the macula requires great precision, I would personally welcome any ergonomic and easy-to-use device to make my surgery safer for patients. I have not had the opportunity to use any of these devices personally, but to be honest, many of them do not seem very practical for the OR given their size. But future developments may refine on this. Precise is a co-manipulation system that downscales movements and filters out hand tremors of the surgeon by asking the surgeon to use the motion controller rather than holding on to an instrument itself. This allows for greater precision and safety in performing some procedures by translating large movements of the hand on the controller into fine movements of the instrument within the eye. And finally, the fully automated surgical system with surgeon supervision. Think of this like LASIK or femto-assisted cataract surgery, where the physician inputs all of the data, but is still required to oversee the treatment protocol, enabling them to step in or alter treatment if something unexpected occurs. Again, these kinds of devices involve numerous high-speed sensors and essentially eliminate tremor, which makes this desirable with regard to patient safety. In summary, retina evaluation and imaging has advanced rapidly in the last 10 years and will continue to do so alongside advances in computing. AI has many applications in routine screening and diagnostics, which will ultimately decrease the burden on providers while increasing access to care. Predictive analytics based on ophthalmologic imaging has the potential to provide systemic risk stratification. Technology will continue to make surgery safer and more efficient, and I believe AI will support rather than replace many healthcare providers. Thank you for your attention, and I'm happy to answer any questions. Here are my references.
Fantastic talk. Very exciting.
What a relief to know that we're not going to be replaced by robots.
I think it's going to be definitely a more supportive role. Even with a lot of the screening, I think there's some concern that providers in clinic won't be needed as much as they are now. But I really think it's just going to enable us to do what we've trained in more, be referred patients who actually need our abilities, even in general ophthalmology practices, optometry clinics. I think we're going to be able to do the more refined skill-based providing as opposed to the screening, which often can bog down clinics at times, I believe, especially in the retina clinic. So hopefully free up time for more valuable patient care.
Just a reminder to our attendees, please use the Q&A feature at the bottom of the screen to type your questions. We want to make this as interactive as possible.
Nick, I thought that was a great talk. It's nice to get in that we're not going to be replaced necessarily, but I do think with the patient population that we take care of and the projected growth of that, we're going to need things. We're going to depend on things like this to allow us to even provide the care for the number of patients that we're going to need to see. It's good stuff.
Interesting, with the development of OCT, most recently we've discovered diseases that we didn't know existed before. And it's interesting looking at your talk with this historical review. It's not new. The invention of the ophthalmoscope led to the discovery of how retinal detachments occurred and led to ultimately how to treat them. So it's an exciting look at the past and excitement and encouraging about look at the future.
Nick, do you think that these, like the deep learning algorithms from fundus photos, do you think that's going to lead to primary care providers getting fundus photography in their clinics, or is it going to be the opposite, where patients go for a routine eye exam and then they end up in a primary care provider's clinic?
I think it could really go either way. I've thought about this a lot, and one scenario where I think this could honestly play out years down the road is almost the equivalent of where the blood pressure cuff exists at your local CVS or pharmacy, where someone would go, go to an area where they're seeking some sort of healthcare and be able to obtain an image that's quite easily obtainable and hopefully get some sort of actionable information from that. So I really think it could play out in both clinical settings. The primary care doctor who gets an image and finds out that they have in a diabetic, referable diabetic retinopathy, and therefore the patient gets plugged in with specialty care, and vice versa. Someone going in for a new pair of glasses, getting an image and, really identifying systemic high blood pressure that wasn't adequately treated for years, and encouraging them to follow up with their primary care doctor. So I think in all clinical scenarios, this could play out to be very beneficial for the population at large.
Very nice. Any other questions or comments? We still have 5 minutes before our next talk.
So it looks like one question did just come in. So the AI is providing recommendations based on analysis with these systems for diabetic retinopathy. That's true. The iArt system obtains 2 images or processes these 2 images that are obtained per eye. And with the algorithm that is designed, and again, it is FDA approved, makes the decision as to whether the presence of more than mild diabetic retinopathy exists. And associated with that would be the recommendation to refer to an ophthalmologist for further evaluation.
Excellent. There's a question, or someone's commenting on the use of OCTA, which I agree with the attendee. Yeah, it's a wonderful technology. I do find in using OCTA, it's a little bit more time demanding and getting the proper segmentation on it. Any tips that you have discovered that makes that process go a little faster? Because sometimes you can't just rely on the auto segmentation. Sometimes it's off a bit.
I 100% agree with that, and actually might comment on that during one of the cases as well when we were looking over them earlier. Even I feel even some images of optic nerve OCTs, the auto segmentation can sometimes be off there. So we have to be aware of that with any imaging software that is providing automatic assessment of images. I think some of the platforms are better than other with regard to OCTA. The Heidelberg, I don't know if, am I allowed to talk about specific names of devices in this?
I think so, yeah. As long as you're not getting paid to do so.
Yeah, the Heidelberg software, I think, is a little more clunky. My experience is you can't really adjust the segmentation areas as well, and therefore, if there is an artifact and you're trying to, account for that kind of independently, it's not very well accomplished. But some other platforms have, I'm forgetting the name exactly, makes it a little easier to kind of move the segmentation areas and kind of see different layers of the retina better.
There's a question about how do you think all this technology will be paid for?
Well, I think like a lot of computing, as time goes on and technology gets better, at least the computing side of things is much less expensive. The technology itself, I think, will be relatively inexpensive in 5 or 10 years. In terms of reimbursement, again, with kind of the idea of cardiovascular risk factors, any problems that affect patients' vision, I think the government, Medicare, has a strong incentive. Many health insurance companies would have a strong incentive to, I think, cover these screening or imaging devices as well, in order to minimize vision loss and the burden on community that really exists when someone goes blind from something like diabetic retinopathy. So I do think that once it's verified and it's been used enough, that insurance companies will likely reimburse for these screening images, is my belief and hope.
I think that's one of the challenges of getting all this new technology. It's all super expensive, and like OCTA is currently not reimbursed. So integrating that into how we take care of patients and how we're required to or expected to use that technology when we buy these super expensive machines and don't get any reimbursement for it. It's hard to integrate that. It's not so well. It's a great question.
I do think OCTA will likely be similar to OCT, where it's still kind of in the early stages where we don't really know how to use it. We don't really know the use cases where it's most important. But perhaps once we identify that, we'll better be have better support to ask for reimbursement for those images.
Doctor, I was always surprised. I think we're all, the most surprising finding from that Google research group a few years ago is how could a machine tell gender based on a photograph alone? Any insights as how that was done?
I zoomed in on the heat map for that. It looks like, honestly, that the neural network was really focusing very closely on the foveal reflex. There's a small little kind of heat map indicator right by the fovea. That's one of the mysteries with deep learning and neural networks, is these systems provide answers and we don't necessarily know exactly what the computer is taking into account aside from these heat maps. That's why some people have some hesitation with artificial intelligence. Is, you know, it's difficult for us to understand it, for the computer to explain what it's doing. But if it's reproducible and verifiable, I don't see why we shouldn't trust it and leverage it.
One other comment, not only is the reimbursement an issue for all of these modalities and technology, but just the time to do that. It still requires someone with some expertise to decide which modality is best, because there is a limited time and how much a patient could spend in the office and what is needed. Any thoughts about that? Well, one day we have, years from now, all modalities are done at the same time with one click of a button.
Well, I think once the reimbursement side is figured out, really that becomes less of an issue. Patients wait a long time in the waiting room, and if there is reimbursement for these images, I think there's certainly the ability for an additional technician who might be trained in one particular software to obtain these images on patients. And again, I think pie in the sky dream would be that something like this just is plopped in CVS, just like someone checks their blood pressure with no reimbursement. If a patient were able to find out really meaningful information about their health by getting an image taken, while I understand the reimbursement side is very important, in terms of really helping people and getting them plugged in, that's where I think the real population benefit is for these technologies.
Someone's commenting about the acceptance of PCPs, of having some sort of technology in their office, like a fundus camera. Any thoughts on what the acceptance would this be? I would imagine it's a limitation in just having the technicians available to obtain the image.
I would think that that's likely the biggest barrier, in addition to reimbursement at this point. But needing to train someone to do something that they otherwise don't need to in the primary care setting, I think would have to be demonstrated great value in order to have them do that. But again, I think with the amount of information that potentially can be gleaned, it may end up panning out that that's beneficial.
Excellent. We'll have a few more moments to discuss this prior to the break, but for now we should go on to our next talk. It will be provided by Dr. Sabin Dang. His topic is on retinal referral timing. Unfortunately, he is unable to be with us live. Hopefully he'll join us later.
Hello, I'm Sabin Dang, and I'm going to be speaking to you today about retina referral timing. If you are listening to this recording, that means I've been called away to an emergency surgery, and I apologize for not being here in person. That's the challenging nature of retina disease. Sometimes patients need emergent intervention to prevent irreversible vision loss. The challenging thing when caring for these patients is determining sometimes how soon somebody needs to be seen or how soon they need to be treated. I put this presentation together to give some helpful tips on what the current evidence shows regarding timing of care for these patients. Here are my financial disclosures. And here's the outline for our talk today. So I'll be covering these areas in terms of how urgent someone needs to be seen. We're going to start off with non-urgent pathology. These are things that can wait and can be seen as the next available. We'll be talking about prompt pathology, and these are patients we personally like to see within 1 week. You will note that some of the things I will present can actually wait up to a month, but however, we at the Retina Institute do like to see them sooner, just in case, and to give the patients the best care possible. We also have urgent pathology, and these are patients that really should be seen the next day. Emergent pathology, and these are patients who require same-day evaluation to prevent vision loss. And then finally, we'll be talking about patients that actually should skip the retina provider and go straight to the emergency department because their problems are more than what we can take care of as retina specialists and often require a multidisciplinary approach. So beginning with non-urgent pathology, we're going to talk about the macular hole. So this is one of our most common surgical referrals, and this is incredibly frustrating for patients because they can actually have very rapid onset of vision loss. Typically the way this occurs is the posterior hyaloid, which is inserted along the retina, will begin separating as normal age-related changes occur. This will induce traction, and when that traction occurs, we eventually can get a small hole that occurs here. At the edges of the hole, it's very common to see macular edema in this case. So one of the questions we get is how often do we need to see macular hole patients, how rapidly do we need to see macular hole patients? And the reality is we like to get these patients to the operating room within a month, so it's not an emergency, but I think prompt attention is warranted. So in the next few weeks after diagnosis, there's a couple things that we use to decide how soon to take somebody for macular hole repair. For example, we can find signs of chronicity. In this patient, if we look at the retinal pigment epithelium here, we can see that there's a slight thickening of the RPE. There's also this elevation and irregularity of the RPE itself, and this finding can be consistent with a chronic macular hole. Additionally, we look at the hole size. So in this patient, this hole size is actually rather quite large. We define large macular holes as having greater than 500 microns, and in these patients they can be more challenging to clear and repair with surgery. Sometimes we opt to have these patients become pseudophakic before we attempt the macular hole repair, which can result in longer than 1 month to repair, but this can often be beneficial because it gives them a higher chance of primary surgical success. The next condition we get frequently referred for is epiretinal membranes. So an epiretinal membrane will be this taut membrane that can grow on top of the retina. I often describe this to my patients as almost a clear piece of saran wrap that grows on the retina. It's sticky, you can see through it, but it is wrinkly and can distort the vision, and it results in irregularity of the retinal contour. As we can see here, instead of nice smooth layers like layers we get on a cake, we have these irregularities. So these are what drive the patient's complaint, most often metamorphopsia and blurriness. These are typically very slowly progressing. I see patients with epiretinal membranes that are visually significant, and oftentimes patients elect to defer surgery for 6 months, and I think that's completely reasonable because, again, these do not grow very quickly. It can be confusing, however. Sometimes there can be a mixed presentation, and it's unclear exactly what the pathology is. In this case, this patient with epiretinal membrane also has significant macular edema. In this case, we do see very prominent epiretinal membrane, so it's fairly obvious in this patient that the macular edema is due to the traction from the epiretinal membrane, but that may not be entirely obvious. Sometimes when you see a patient with cystic changes, you may think this is diabetic macular edema or retinal vein occlusion, in which case more prompt evaluation may be beneficial. Our next patient here is another patient that can often be very scared because of their profound vision loss. This round object sitting in the bottom of the vitreous cavity is actually a patient's natural crystalline lens. So this patient has never had cataract surgery. They likely sustained some trauma, or they may have Marfan's or some other disorder that caused their lens to fully dislocate and end up floating in the vitreous cavity. These patients will report sudden and profound vision loss. Now, when we talk about lens material in the posterior segment after cataract surgery, that can be a much more urgent situation, as we will talk to later, because of the significant inflammation induced by the lens. That inflammation is because lens particles are exposed to the posterior segment. In this case, this lens is entirely encapsulated by its natural capsule. The lens fragments and lens particles are all safely tucked inside. The body is not irritated or inflamed by this process. Other than the profound vision loss, this patient can be safely observed technically indefinitely. Again, we still like to see these patients ideally in the next few weeks after diagnosis, so we can come up with a surgical plan and try to help them regain their vision as soon as possible. So to recap on our non-urgent follow-up, most of these consultations still need to be seen in the next 2 to 4 weeks, and often we can accommodate that even though some of their pathology can wait for many months. If the diagnosis is unclear, or if there's a concern for more urgent pathology, like I gave as an example in the epiretinal membrane case, maybe that macular edema is from an RVO and it's unclear, those are definitely warrant a sooner evaluation, and you can send them to us with a question. You can say, is this an epiretinal membrane or an RVO? And we'd be happy to take a look and determine which one it is. Moving along to prompt or within 1 week conditions. The first one we're going to talk about is the one I get the most questions about, and that is retinal detachments. There is a lot in literature regarding retinal detachment timing, and the truth is we are still exploring what needs to be done and how soon. In this case, I can clearly show you a patient with a fovea off detachment, but if you look, technically they are partially macula on. In this case, this area of the macula is still attached. The area in red, the area in green is detached. What matters most for me is actually the fovea. So if the fovea is detached or not, that really is what's indicative of surgical timing. And I'm going to show you a recent study that kind of highlights this difference. This was a study performed by Jeremy Wolf and his colleagues, and it's looking at the long-term visual outcomes and the timing of surgical pair of fovea splitting rhegmatogenous retinal detachments. And I really appreciate that the authors here have called out that the distinction between macula off and macula on detachments is really not as informative as we would like it to be, and it isn't as prognostic, for what a patient will experience long term. For example, these are patients that in the first frame have a macula on detachment, in the second frame have a macula on detachment, in the third frame technically have a macula on detachment, meaning there is a section of the macula that is attached. Now these 3 patients have profoundly different visions at presentation, and it will actually have, as you will see, very different outcomes surgically. What the authors propose is a better distinction is whether this is a fovea on detachment, a fovea splitting detachment, or a fovea off detachment. Fovea splitting, meaning part of the fovea is attached, part of it is detached. Where the fovea on group, the fovea is fully attached all the way around. And in the fovea off group, the fovea is completely detached all the way around. These authors identified surgical timing and visual outcome, and let's take a look at some of the. Here we go, and we're going to start off with the fovea off group because that's the one that we would traditionally consider macula off. And we can see there's a wide range of visual acuity at last follow-up, and we can see this widespread. Overall, there is a slight trend, meaning an upward slope, where longer time to treatment results in slightly worse vision, but this is still a fairly flat line. So these patients, if they're taken care of within a week or so, tend to do pretty well. You'll find that in our group, sometimes we will extend patients to up to 2 weeks when they have a fovea off retinal detachment. And oftentimes this is because there's some chronicity there, or there's some other pathology or other considerations that we need to address and optimize before taking them to surgery. A common one is we need them to get medical clearance due to some cardiac issues. So in this case, with fovea off, again, I think that's more akin to what we would normally describe as macula off detachment. We see preferably treatment within the first week. Occasionally we will extend beyond the week, and it's a fairly flat line, so getting them in a little bit sooner is ideal, and we do try to do that as a group. Now let's look at the macula on, fovea on group. So fovea on, again, is going to be our most critical one. And if you look at this study, most of these patients were taken care of either on the day of evaluation, the next day, or the day after that. Later in this talk, I'm going to show you that sometimes you can actually go much longer than this for fovea on detachment, and we'll kind of talk about what considerations those are. But the bottom line is that's something for us to determine as retina surgeons. So when you see a fovea on detachment, we will talk about the timing for that. So for macula off detachment, we do like to see them fairly soon. Usually we typically recommend within a week, and we have many ORs running every day, so we often have good chances of getting them in fairly promptly. Now the interesting thing about this study, and I'm going to highlight this, is going to be the fovea splitting detachment. If you look at the fovea splitting detachment, there's this interesting trend. It's not significant, but the longer you wait, the better they did. Now that's a funny thing to think about. Now, from my personal experience, I can tell you that fovea splitting detachments, sometimes when taken emergently to the operating room the same day, can get this terrible distortion right through the fovea from retinal folding that occurs there. And sometimes actually letting the retina detach a little bit further can result in less of that retinal displacement and distortion. And I do wonder how much of that is driving this curve, but the authors did not really address that specific thing. I think fovea splitting detachments are safe to be treated fairly similarly to fovea off. We do like to get them a little bit quicker because more of that macula is attached, but they are a less urgent pathology. The next one we'll be discussing is central retinal vein occlusion. Again, something a patient can be very scared about due to sudden vision loss. And when you look inside the eye, it can look very scary. There's hemorrhage everywhere, there's exudate everywhere, the nerve margins can be blurred, there's tons of edema. Sometimes these patients can have an afferent pupillary defect. The data shows that we actually have several weeks to initiate treatment for these patients. However, we do like to get treatment on board soon. The reality is many insurance companies now require prior authorization to treat these patients. So not only is it a patient coming in to be evaluated, but we need the time to obtain the prior authorization for their injection therapy. So getting them in within a week is often very helpful. And then we can make the diagnosis, obtain the prior authorization, and often initiate treatment within 2 weeks of onset of symptoms. We're next going to talk about floaters and flash. So this is another one all of you see a ton. I mean, these patients present to the emergency department. They're calling their optometrist and their comprehensive ophthalmologist with sudden onset floaters and flashing lights. Now the question is, that is a symptom of retinal tear and detachment, and we know those are urgent things, but they can also be symptomatic of just normal aging of the vitreous body, and those are not emergent pathology. So the question is, how do we determine who needs very prompt attention and who needs deferred attention? There was this interesting study that was published out of Mayo in 2022 looking at the clinical outcomes following an implementation of a flashes and floater protocol. And I'm going to share that. That protocol defined patients who would need prompt evaluation and those who would otherwise need evaluation within 1 month. So if patients answered yes to any of these questions, whether they had a history of retinal detachment or tear, history of ocular trauma or surgery within the last month, if they had a visual field defect, and that's if patients self-reported one, or if there was one identified on confrontational visual field, or if the visual acuity difference between the two eyes was significant, which was defined as 2 lines or greater, those are patients that were seen, Mayo referred out to be seen by an ophthalmologist within 48 hours. Otherwise, they recommend an evaluation within 1 month. Our group typically recommends that if somebody has a new onset of flashes and floaters and has an exam without any overt pathology, those patients we usually typically see within a week. But the truth is, if they are negative on all 4 of those symptoms, they're probably safe to be evaluated in the month. These researchers found that there was no case requiring emergent care that was not identified by the triage protocol, meaning it was really good at ruling out people who had emergent pathology that need to be checked out. Again, if any of your patients has one of these 4 things, I think it's worth letting us know, and we'd be certainly very happy to accommodate seeing them within 48 hours if that's what you feel is necessary. But again, if it's flashes and floaters, typically we bring them in a week, and if they're seen within a month, that's probably totally adequate as well. The next one is going to be a cherry red spot in a patient. So this is going to be a central retinal artery occlusion. The central retinal artery occlusion is another sudden onset vision loss. These patients are very scared. In this case, if the patient is symptomatic for over 2 weeks, oftentimes this is something that you can refer to us within a week, and we can formalize the diagnosis and make a determination of what needs to be done as an outpatient. I'm going to be talking about artery occlusions in an upcoming section. Our next area is going to be exudative macular degeneration, and one of the hallmarks of exudative macular degeneration is going to be subretinal and intraretinal fluid. Sometimes they may have disciform scarring. They're typically associated with significant acute changes in vision loss. These patients we do like to see within a week. They do benefit from prompt anti-VEGF administration. Again, the reality is a lot of these patients now need prior authorizations before initiation of treatment. So it's important to counsel patients that they're going to come in, be evaluated, and may need prompt treatment. Typically, if they do need treatment, we make the diagnosis. If we can do same-day treatment, we do. But if the insurance requires authorization, sometimes that takes 2 to up to 7 days. And that is a reasonable time for new diagnosis of exudative AMD. In rare cases, we see some very aggressive exudative AMD presentations. In those cases, obviously, we find a way to get the patient treated same day as evaluation, but those patients are typically safe to be seen within 1 week as well. Our next case looks like a pretty big mess. This is a patient with diabetic retinopathy who has developed retractional retinal detachment. This patient is going to need extensive work. These can be very scary, again, for the patient due to this profound vision loss. They're scary for the referring doctor because the eye looks like a scrambled mess on the inside. But the reality is often we time these treatments over the course of weeks. Patients like this receive lasers, injections prior to getting surgery to calm down the eye, and it's a very complex treatment pathway. Some of them need cataract surgery in order to adequately treat this disease. Again, we like to see these patients within a week so we can get that whole process started. There is going to be the exception on patients who also have NVI or neovascularization of the iris or neovascular glaucoma in the future. So to wrap up prompt follow-up, these are conditions where we worry about delaying intervention greater than a week could lead to a worse outcome long term. It's important to counsel your patients regarding possible treatments. You can leave the details to us, but letting them know that you're sending them to retina specialists for some sort of intervention, and that may involve surgery, laser, or injection. It's important to emphasize that they're not going to get same-day treatment. Again, the reality these days is prior authorization is a very big part of what we do. These therapeutics are very expensive. We want to make sure patients are well cared for, but also do not sustain an unneeded financial burden in getting their appropriate treatment. Now we're going to go into the really worrisome stuff. And if you're listening to this recording, that means I'm probably taking care of one of these. Next day urgent stuff. So in this case, we've got a patient with a large horseshoe tear in the temporal periphery. And technically, you could call this a small detachment. There is a little bit of fluid right around here. So if you wanted to say this was a small macula on detachment, that would not be incorrect. But again, this is I think better classified as a horseshoe tear. Typically, we like to see these next day. Within the next day, I should say. These patients often do require laser treatment. Occasionally, you'll send a patient to us and we'll say, hey, guess what? They're lucky. They've got some pigmented naturally and they won't need anything. Or sometimes we'll say, hey, you know what? There's actually too much fluid there. We can't do laser. We're going to go to the operating room. It can vary quite a bit. One of the things that can be confusing for some referring doctors is this a detachment or is this a tear when you call us? And the reality is if it's a small enough detachment where you're kind of on the fence, it's probably safe to treat it as a tear and have us see it the next day. Again, if you're worried that this is truly a macular detachment, we'll be talking about those in just a moment as well. Here, this fuzzy picture represents a vitreous hemorrhage. Now, I shared a picture with a patient who had a hemorrhage due to known diabetic complications, but let's say you have a patient with no known history of diabetes and they come in with a vitreous hemorrhage. I'm actually pretty worried about this patient. The statistics are if it's a non-diabetic vitreous hemorrhage, chances are there's something that a retina provider needs to intervene on. So typically we like to see them usually the next day. Oftentimes we will do an ultrasound. We may find a retinal tear or a detachment underneath the hemorrhage, in which case we will be taking the patient to the operating room. Sometimes we identify that this is actually a retinal vein occlusion that was hidden in the corner and that was now bleeding, and that's what caused it, and the patient needs injections. And occasionally we find that these non-diabetic vitreous hemorrhages are actually diabetic vitreous hemorrhages and the patient just had no idea that they had diabetes. And when we look at the fellow eye and perform angiograms, we find evidence of the diabetic retinopathy that caused this. Here is a patient that's got a lot of things going on. You can see that there are these yellow deep lesions in the choroid. So this would be our white dot syndromes. These can be kind of scary and they can be challenging to manage. There's so many things that this could be. We could talk about syphilis, we could talk about various infections, we could talk about autoimmune diseases. These patients deserve to be checked out within the next day, just so we can get them on the right path. We may not start treatment right away. We may need to get blood work first, but at least we can get the ball rolling. The cataract surgeon's most dreaded complication here, or at least one of them, these are fluffy retained lens fragments after cataract surgery. When cataract surgery goes wrong, it's the surgeon feels terrible. The patient is scared because they thought they were going to be jumping up and down and seeing 20/20 the next day, and now they're finding out they're going to need to be seeing a retina surgeon for a urgent consultation. Typically, we recommend giving these patients copious steroid drops, letting the eye calm down, letting us see them the next day. We'll take a look and see how much fragments are left. Sometimes we're lucky and there's so few that we can just watch it. Sometimes it's rip-roaring inflammation and we have no choice but to take the patient fairly urgently to surgery. In my practice, I typically like to let the eye cool down for about 3 days with some aggressive steroid regimens. to help make the surgery a little bit smoother. So wrap up our urgent next day. These patients are, usually have sudden onset vision loss. Prompt evaluation is needed. Initial treatment, though, may range from at the time of evaluation to several days or weeks later, but the initial evaluation does deserve to be soon. Patients can go home after you see these patients in your clinic, and we can safely coordinate the care to be the next day, including on weekends, and we can do that by phone for your patients to help them out. And this is the tip I made. If this is a tear or macular detachment and you're not sure, it's still usually safe to refer within 24 hours because detachments typically do not progress quickly. One of the tips I can give you is that if you are worried or if your patient is unwilling to see us same day, you can position it so the retinal tear is on towards the ground, and then gravity will help pull out that fluid and it will actually help prevent the detachment from progressing. And in some cases, a small detachment will reabsorb with that positioning, and we can laser the patient instead of having to take them to the operating room and giving them a gas bubble. Now let's talk about the patients that really need to see us the same day. So they're in your clinic, you see them, you see one of these conditions, it's time to pick up the phone and call the Retina Institute and have your patient wait until we can coordinate the follow-up. This one is probably the actual dreaded complication after cataract surgery. This is a endophthalmitis after cataract. This is a hypopion, so an eye full of pus. This eye needs emergent treatment. It doesn't matter what the vision is. This eye really needs antibiotics on board fast. Call us, let us know you have an endophthalmitis, and we will get the patient taken care of with intravitreal antibiotics. Some of them will need surgery as well. Next up is the neovascularization of the iris, neovascularization of the glaucoma. I shared with you a patient earlier with really terrible diabetic TRD. The inside of the eye looked like a scrambled mess. What's interesting, sometimes you can get an NVG patient where the back of the eye actually looks okay, but they've got these crazy iris vessels growing on in the front. If the pressure is high and these iris vessels are present, got to get them in soon because NVG can go south on us fast. If we can hit it hard and hit it fast, oftentimes with injection, lasers, drops, we can help try to salvage these eyes. Often we do require the assistance of our glaucoma colleagues because these patients, even with full court press from the retina perspective, often do not do well. Their diabetes is so bad that this ischemic drive is almost unstoppable, but you got to do what we can do, and you can save some of these eyes if you can get to them soon enough. Now let's talk on the fovea on retinal detachment. So this patient is got a fovea clearly on, and they've got subretinal fluid encroaching in onto the fovea. This is definitely a patient I would say a same-day evaluation is warranted. We would want to take a look. But I'm going to emphasize it's very important you don't tell the patient that they're getting surgery same day, because that's not always the case. Some of these detachments we don't actually operate on the same day. And I'm going to give you a study that was looked at. This was asymptomatic rhegmatogenous retinal detachments in outcome of patients without initial surgical intervention. So this is by Dr. Flynn and some of his colleagues. They looked at patients who were found to have a retinal detachment at a routine eye evaluation, but had no symptoms. So in these cohorts, 20 eyes, they just watched them. They didn't do surgery. It was interesting to me that 80% of these patients had detachments that were posterior to the equator. So these were not just small little detachments off the corner. They were kind of large. Only 10% of these patients demonstrated progression and were taken to the surgery, meaning 90% of patients didn't progress. That's a pretty large number. And we see these patients with macular detachments in our clinic all the time. 78% of patients had pathology in the fellow eye, including 11% of patients who actually had bilateral asymptomatic detachments. So those are obviously very concerning. So that patient I actually just showed you presented to me with a macula on retinal detachment, and I had a talk with this patient, and I told her what the symptoms were, what the findings were, and I did recommend surgery because of how close it was to the fovea, but she was really worried this was completely out of the blue for her. And you know what? I actually repaired her about 3 months later. So goes to show that you don't always have to get to the detachments right away. Her detachment was clearly a long, chronic, slowly expanding one. She probably could have been waited another 6 months and barely would have budged. But we did follow-up examinations on her. She was seen a total of 3 times between date of diagnosis and date of surgery. And you know what? It also gave her plenty of time to get second opinions and just feel comfortable about the process. And in that case, I did a scleral buckle and she did great long term. Same day patients, to recap, these are patients incredibly high risk for blindness. As I mentioned, not all of them need same day treatment like that macula on, fovea on retinal detachment, but it's sometimes hard to tell, and that's where we're here as retina specialists, happy to help. Don't tell your patients they're going to be getting surgery same day, because that can lead to confusion, and oftentimes surgical timing can be dependent on a multitude of factors. We recommend you keep these patients in your office until a plan of transition of care is established. And just to be safe, tell your patients not to eat or drink anything until evaluated by the retina surgeon in case emergency surgery is indicated. Finally, I'm going to finish up with the patients that shouldn't come to the retina specialist and probably are better going off to the emergency department. And so the first one is going to be the central retinal artery occlusion, but this time it's a patient who says, I lost my vision 2 to 3 hours ago. Now, there may not be an ophthalmic intervention we can do to save this eye, but the reality is these patients just had a stroke. You know, that when they occlude the central retinal artery, they have such a high chance of actually having a cerebral infarct in the next few hours, days, weeks. So in these patients, you treat it like an acute stroke. The ideal thing to do is send them to the emergency department, preferably a place with a stroke center, and have them get that stroke workup. If it's truly a rapid onset, just in the last hour or so, in some cases, some of those stroke centers do have therapeutics in which they can administer clot busters to try to reperfuse the retina. That's a pretty rarely done thing, but it is a possibility. Those patients, if they come to the retina specialist and waste those additional hours, we may lose those opportunities, and that therapy can only be done in a hospital inpatient setting. Again, these patients are high risk for stroke. Many patients have had strokes shortly after having a central retinal artery occlusion. Getting them plugged into a stroke center can really save their lives. Ruptured globes. I think this one doesn't really come to retina often, but every now and then we do see something that is a ruptured globe, and these are patients that often are better served going to the emergency department. Sometimes they need IV antibiotics preoperatively, and they can do better in that situation. So those are the two that I'm going to say are really emergency room things. As you can tell with retinal pathology, the vast majority of it we actually take care of in the outpatient setting. But I do like to emphasize that ruptured globes and acute central retinal artery occlusions may be more benefited by going to the emergency department straight away. All right. And then with that, I've covered the kind of summary of that. I hope this was an informative. If you have any questions, again, I'm sorry I wasn't here to present to you in person. My email address is located here, sdang@rc-stl.com. I'm always happy to take your emails about general questions on these type of topics. And I appreciate your attention, and I look forward to talking to you in person at some point in the future. Thank you.
Thanks, Dr. Dang. Always an exciting talk. One question from the attendees is that, well, is there a way to position a patient maybe to limit the spread of their detachment? I think we'd all suggest that, for example, you would want to basically put the detachment in the most dependent position. So if a patient has a macula threatening detachment in their left eye that's temporal, you would want that patient to lie on their left side until they can be evaluated or favor doing so in an effort to try to prevent that detachment from spreading into the macula and losing more vision. I was curious what our panelists think about retinal timing or referring of retina patients. Any other comments?
I think, again, Dr. Dang did a great job. Sometimes in acute artery occlusions, there is some data to say that we can possibly intervene in the office with ocular massage or anterior chamber paracentesis, where I've seen a result within hours. So sometimes that's something to consider as well. It's a hard thing to decide. Do we intervene, and waste the precious hours that they could go to the emergency room and get a clot buster. The reality is most ERs aren't equipped to do clot busters, unfortunately. We had a trial that looked at that actually was a selective delivery of the clot buster into the central retinal artery, believe it or not, canalization into the ophthalmic artery, which went into the central retinal artery. And unfortunately, the trial determined that the risk was too high in those patients and the outcome was not great. So I think now they just do intravenous treatment with the clot busters.
I'm going to be talking more about that, but yeah, you're exactly right. And unfortunately, that trial included patients that had central retinal artery occlusions greater than 4.5 hours. So that might have decreased the benefit of having the thrombolytics, but there's all kinds of issues surrounding that. Someone asked, and this is an important question, the good ERs in our area. So the stroke centers are basically Mercy and BJC. St. Luke's can do it also. No one is really doing intra-arterial thrombolytics. It would require an interventional neuroradiologist, and there's so many protocols that I'll go into that kind of prevents being able to do that, and there's a high risk of hemorrhagic brain injury. Oh, Dr. Dhaliwal, our colleague practicing in Georgia, 3 large studies from Vancouver, Beaumont, and the UK, with 1,200 and 1,500 cases, each demonstrated that an acute retinal detachment that is MAC-off can be repaired within 5 to 6 days without loss of central visual prognosis. So important to think about. I don't know. I always think about when I see a patient, like what would I do for my family member, or what would I have done if I had vision loss with a retinal detachment? Curious what you guys think about that. Does that enter into your mind, or do you stay strictly according to data?
Depends on the availability of the operating room. But I would do it sooner rather than later. If I had space, I wouldn't do it after hours, but the first available during regular hours, I would do.
And I also think there is a benefit to having the eye team in particular. Sometimes you don't get the people that are eye specific in the operating room, so it makes more sense to wait until you get the eye team to help.
I totally agree with that, Avi. The last thing you want to hear at 11 o'clock at night is, Dr. Anasagi, I've never done this before. Can you explain to me how to do this, from the scrub tech? So yeah, we don't want to be in that position.
All right. Well, we're just past time in going into our break, so we'll meet back at 10:25 and continue with Dr. Durrani's talk on advancements in neovascular AMD treatments. As you guys are breaking away for your break, feel free to grab some coffee, take a rest break. These talks will be recorded. They are being recorded and will be available on our website at tri-stl.com. Keep in mind, though, that to receive continuing education credit, you do have to meet that deadline. So it's not accredited for as enduring material. You can't log onto the website, 2 or 3 weeks later, watch, and then try to receive credit. You have to meet the deadline for the credit, but you can go back and review the information online. So let's go ahead to our break, and we'll see you in a few minutes. Okay, welcome back, everyone. All right, we're going to go on with our next talk from Dr. Durrani, who unfortunately couldn't be here this morning live, but we'll get to hear her via recording on her discussion of emerging treatments for neovascular AMD.
Good morning, everyone. My name is Ali Durrani, and today we'll be discussing emergent treatments for neovascular AMD. These are my disclosures, none of which are relevant to this talk. In terms of treatment modalities for AMD, I'd say it's obviously been a very rapidly changing landscape over the past 3 to 5 years for advanced AMD. We have a host of new treatment modalities that have been introduced and are being explored in clinical trials. It can make it very challenging to keep up with even as a practicing retina specialist, but it's a very exciting time. The goals of this talk are to review previous and current established treatment options for exudative disease, and to discuss the current landscape and future directions. The costs associated with exudative macular degeneration can be both direct and indirect. This includes, of course, the cost of treatment, services, equipment, low vision aids, transportation, and then those indirect costs, which include lost productivity and workplace costs as well. So this is an important disease to treat, as is any disease that impacts blindness. Prior to 20 years ago, patients with exudative AMD were really expected to have imminent vision loss, although there are a few treatment modalities that did exist prior to the advent of anti-VEGF agents. In the 80s and 90s, thermal laser was used for extrafoveal, juxtafoveal CNVM, which is validated by the macular photocoagulation studies. And as we know, this at best really only slowed vision loss down. And this is due to the fact that there are high risk of recurrent rates and profound post-treatment scotomas due to the destruction of nearby healthy retina cells. PDT, which was approved for predominantly classic CNVM and introduced in the late 90s, involves the use of a photosensitizing dye. Unfortunately, even with PDT, we found that although the chances of significant vision loss were reduced, it rarely improved acuity. And so with the advent of VEGF inhibiting agents, PDT has also been relegated to an adjuvant role for exudative disease. Although it's certainly not the focus of our discussion, I think I'd be remiss not to mention the brief foray into surgical management of CNVM or submacular hemorrhage with AMD. In the late 80s and 90s, this was a hot topic, and submacular surgery trials, which were conducted in the late 90s, early 2000s, and published in 2004, included Matt Thomas, who was a recent retiree from TRI. Unfortunately, they found a significantly higher rate of RDs in these patients, and so for the most part, surgical management has largely been abandoned. So as I've alluded to, anti-VEGF agents have then come along and really changed the landscape, and the paradigm has shifted in terms of treatment of these patients as of the mid-2000s. The common denominator in all forms of subretinal choroidal neovascularization is subretinal hypoxia. This is what results in impaired subretinal blood flow, and this leads to upregulated VEGF, which is why anti-VEGF agents work so beautifully for the disease. You can see the more commonly known agents listed here. The newer agents are listed at the bottom, including brolucizumab, susvimo, faricimab, and ranibizumab, Anuna, which is a biosimilar. Some of these agents may have potential longer durability of treatment, which may allow for patients to go longer between injections. We'll kind of parse through these individual treatment modalities in later slides. So over 11 million Americans have some stage of AMD, with ophthalmologists performing 2 to 3 million injections annually. Trials have shown that more than 90% of patients can keep their vision when they're treated appropriately, but in the real world, that percentage is much lower. It's closer to 50%. We believe, of course, that this is due to the undertreatment of these patients. So where are we today and where are we headed? Real-world outcomes with anti-VEGF therapies, unfortunately, often do not match the results of these prospective clinical trials, and we think this is because of the high burden of treatment, which results in relative undertreatment in the real world. Patients have a difficult time getting into the office to get their treatment. And so emerging treatments, or emerging therapies, I should say, are focused on making headway in this and trying to address the unmet need for more durable suppression of disease activity. This includes new anti-VEGF molecules, biosimilars, refillable implants, molecules targeting other factors, gene therapy. So in my mind, what would the holy grail treatment look like? For me, it would be single, permanent, minimally invasive. But as we all know, we're not quite there yet, although maybe we're getting a little bit closer. This is a busy slide, but it's just to show that it's a really exciting time to be a part of clinical trials. This is a slew of trials that we've been involved with at TRI. And as you can see here, we're making a lot of headway due to the just vast number of investigations that are underway. So there's a few new players in the game, as I mentioned before. These are the ones bolded at the bottom, which we'll discuss. Brolucizumab, which is known commercially as Beovu, is an anti-VEGF medication or a potent inhibitor of VEGF-A. It was approved for the treatment of neovascular AMD by the FDA in 2019 in October, subsequently also approved by the European Medical Agency in 2020. It has a low molecular weight that allows for a higher molar concentration in the same volume, which allows for potentially better penetration in the deeper layers of the retina. And you can see here the cartoon depicting the antibody fragment, or the size of brolucizumab in comparison to aflibercept. So these cartoons show the difference in brolucizumab, which is on the far right, in relation to both to aflibercept and bevacizumab and ranibizumab. So the trials that were conducted include Hawk and Harrier, which were the phase 3 trials in which patients were randomized to receive brolucizumab versus aflibercept. And after loading with 3 monthly injections, brolucizumab treated eyes received an injection every 12 weeks or were interval adjusted to every 8 weeks if disease activity was present, and aflibercept treated eyes were receiving every 8-week dosing. These studies found that patients who were on brolucizumab were able to be maintained on Q12-week dosing in approximately 40% of patients. Unfortunately, as most of us know, the story really didn't end here. Reports began emerging after the commercially available use of brolucizumab of intraocular inflammation in patients who had been receiving the injection, of which the mechanism still remains to be unknown. There's theories, of course, which include possible immune response to the drug itself, possible responses to protein byproducts within the medication, differences in pH, potential residues, silicone oil aggregates or protein aggregates, or even endotoxins. However, the rates of intraocular inflammation in the phase 3 trials were known to be higher than, for example, aflibercept, as high as 4%. And again, the reason for this remains to be unknown. Most concerning were the reports of occlusive retinal vasculitis following injection, as you can see here demonstrated by the images with the fluorescein angiography on top and the OCT on the bottom, demonstrating intraretinal hyperreflectivity consistent with ischemia. Obviously, patients that have disease such as severe as this will have profound, devastating effects on their visual acuity. Further published reports, this one in particular in ophthalmology, noted a slightly higher incidence of intraocular inflammation of approximately 4.6%, with additional cases of retinal vasculitis that caused moderate vision loss in patients as well. So you may be asking the question of where do we go from here? Is brolucizumab still a drug that is commonly used? I think that's a difficult question to answer, specifically because I know that many of us were initially very excited about potential durability of treatment for patients who are on this drug. That being said, I think the concern due to the higher rates of inflammation have led most of us to be quite gun-shy in use of this drug. Most reported cases of brolucizumab-associated inflammation did arise when reported to the ASRS in the first few months of treatment. That being said, in Hawk and Harrier, actually about a quarter of patients did have inflammatory events occur after 6 months. So again, even if we had initiated the treatment early on with those patients when the drug was first approved, there's still theoretically a risk in later years that the patient may have subsequent inflammation. I personally am not generally using this drug. It may confer benefits, for example, for patients who have difficult to control fluids in the sub-RPE region. But I think for me, the risk is not worth the benefit, but I can see that in a certain subset of patients, it may be something helpful to have in your armamentarium. Switching gears here, faricimab, which is FDA approved in January of 2022, is a bispecific antibody for both VEGF-A along with Ang2. Ang2 is actually a cytokine associated with vascular destabilization and inflammation. Theory is that dual blockade of both of these may bring synergistic effects in treatment, and then the modified FC region shown at the bottom of the cartoon there may actually reduce systemic exposure and inflammatory potential. Faricimab studies have results shown that when compared to aflibercept, significant and comparable benefits at the end of the trial in terms of durability were shown. So 40 to 50% of patients were receiving injections approximately every 16 weeks for maintenance, whereas over 3/4 were able to be maintained on injections every 12 weeks. I think the key takeaway from this in regards to faricimab is there is definitively a potential benefit for patients who were unable to extend with other medications. Again, the durability here is key. Patients already have challenging time getting into the office for their treatments, whether it be due to transportation issues or illness. So I think this will be invaluable in our armamentarium going forward. The port delivery system, otherwise known as Susvimo, which utilizes ranibizumab, was approved by the FDA in October of 2021. It's a surgically implanted reservoir that's refilled every 6 months. The phase 3 trial that looked at this port delivery system was coined Archway. They found that the use of the port delivery system every 24 weeks was non-inferior to monthly ranibizumab, and you can see the cartoon on the right demonstrating the placement of the port. Unfortunately, the story isn't over here either with the port delivery system, despite most of our excitement in regards to the potential durability of treatment for a large subset of our patients. In October of 2022, there was a voluntary recall of the port delivery system by Genentech due to concern for potential septum dislodgement into the implant body. The company uncovered the defect while testing its commercial supply by repeatedly puncturing Susvimo implants with a needle. You can see here on the cartoon on the bottom right, in the orange circle is a photograph of the septum as it should appear, a concern for dislodgement into the implant body leading to possible conjunctival retraction and erosions. The higher rate of endophthalmitis with the port delivery system also is very concerning. Clinical trials, 2% of patients who had the port delivery system placed experienced at least one episode of endophthalmitis. To put this in light, in patients who receive intravitreal injections of anti-VEGF agents, the current reported late rates in the literature are generally in the 1 in 3,000 range. As I've alluded to, many other clinical trials are currently ongoing looking at newer treatment modalities for exudative disease. There's a few other things I think that are on the short-term pipeline that I'll reference here in the upcoming slides, and some other drugs, treatment modalities that are in the phase 2 trials, such as gene therapy, that I'll also touch on. One potential drug that we may be hearing about in the near future is 8 milligram aflibercept, which was found in a report released by Regeneron to meet primary endpoints in terms of having a majority of patients maintained on Q12 and Q16 week dosing intervals. We're going to switch gears here and discuss gene therapy for exudative AMD. The interest in gene therapy for AMD has been renewed with the 2017 approval of Luxturna by the FDA. There's 3 general approaches to gene therapy for AMD, including subretinal, suprachoroidal, and intravitreal, with the goal of gene therapy being to employ the body to make its own anti-VEGF by inserting a virus into the person's body that carries anti-VEGF gene. Each approach will have its challenges, such as potential incitement of inflammation or whether or not the drug can bypass the ILM in intravitreal delivery. These are the 2 big players that we're looking at right now. So RGX-314 is a recombinant adeno-associated virus gene therapy vector for a monoclonal antibody fragment that binds to and neutralizes VEGF, whereas ADVM022 is a gene therapy product that's designed to express the aflibercept protein within retinal cells after a theorized one-time injection. This is currently moving into phase 2 trials. So with the improved gene factor efficacy, this is the potential to achieve long-term sustained anti-VEGF suppression. So RGX-314, which is produced by REGENXBIO, both subretinal and suprachoroidal injections are being explored. The subretinal delivery program requires surgical intervention, and this has completed phase 1 and 2 trials in about 42 patients with 2 years of follow-up. This has demonstrated tolerability, stable to improved vision, retinal thickness, and a meaningful reduction in central retinal thickness with reduced injection burden with higher doses. Further trials are actually enrolling patients looking at RGX-314 in relation to monthly ranibizumab or bi-monthly aflibercept. Phase 2 Aviate is actually a multi-center open label trial looking at the safety and efficacy of RGX-314 in terms of suprachoroidal delivery. This is exciting because it would move gene therapy to the office setting and avoiding the potential risks of vitrectomy and iatrogenic retinal detachment. And so there's been a few mild adverse events that have been reported, including the risks of a risk of inflammation seen in approximately 20% of patients. However, research had noted that these cases of inflammation resolved with topical steroid drops alone. ADVM-022 gene therapy is an intravitreal injection designed to potentially allow retinal transduction across the ILM. This is a gene therapy product designed to express the aflibercept protein within retinal cells, and the phase 1 trial showed a 80% reduction in the injection burden of patients, and this is currently moving into phase 2 trials. The results of the 2022 ASRS PAT survey found that the majority of retina specialists within the United States were primarily concerned with the unknown long-term consequences of the viral vector, followed by the potential risk of intraocular inflammation and complications from surgery in regards to subretinal gene therapy. So I think the survey is still out on these. These trials are still in the early phases. We're making headway, and I think as the next couple years advances, we'll find out more in regards to the potential use of these products in the real world setting. So we're going to switch gears here for a minute. We're going to quickly discuss biosimilars. I think it's relevant to this topic because it is a hot topic within the world of retina and ophthalmology. So just to recap, a biologic. What is a biologic? It is one of the fastest growing medications in the United States. But it's also amongst the most effective and expensive drugs available, and they currently account for only 2% of prescriptions, but 37% of net spending on prescriptions. So a biologic is a genetically engineered protein, and it's derived from human genes. Those genes are expressed in cell lines that are being asked to produce a large protein. Each biologic has a unique manufacturing process within a living cell line. So rather than simply copying a small size molecule, which is how a generic works, a biosimilar manufacturer must actually reverse engineer to create a final substance that behaves in a biosimilar fashion. So a biosimilar is a product that has been directly compared with the original FDA-approved biologic, which is coined the reference product. The reference product has been approved in a separate application demonstrating safety and efficacy. So the purpose when producing a biosimilar is to demonstrate similarity rather than to establish safety and efficacy. This involves an extensive structural and functional comparison of the molecules to establish there's no clinically meaningful difference in terms of safety, purity, and potency. But clinically inactive components can have minor differences. So there's actually currently 2 FDA-approved biosimilars for bevacizumab. And so the story behind this is upon initial approval of these drugs, multiple insurance companies tried to say that these biosimilars should be added to ophthalmic step therapy protocols, even though neither one of those biosimilars to bevacizumab had actually been studied in the eye, and both contained potentially toxic excipients when injected into the eye. So the Academy contacted CMS and pointed this out, and so the indications or permission to use these biosimilars was revoked at the time, but the potential for use of ocular biosimilars in step therapy was actually confirmed. So ranibizumab nuna, which was approved in September of 2021, is the first biosimilar to ranibizumab commercially known as Lucentis. This became available commercially in July of 2022 and is priced approximately 40% lower than ranibizumab. So the potential FDA approval and commercially available use of these drugs may change the way that we are treating these patients if insurers are requiring us to potentially use step therapy for cost-saving measures. I think the takeaway point from all of this for me is that we need to demonstrate that these drugs are first and foremost safe to inject in the eye before being required to use them, to ensure that we are showing that the efficacy, safety, and tolerability are analogous to the biologics that have already been well studied and approved. So I will end this talk on that note. I know that it's been a very dense talk with many different drugs that have been discussed. I hope I was able to give you some refreshers on some of the things that we've been using and some of the newer things that have emerged. Please contact me if you have any questions.
Thank you, Dr. Durrani. And again, these talks will be recorded and made available on our website for further review after the fact. Just a question to the panelists. Have you guys had some experience using the biosimilars?
I had some experience using BioVis. It's identical to the reference product, ranibizumab, Lucentis. I haven't used Cimerli yet. The data that led to the approval of BioVis made me more comfortable using BioVis because they had 1 year data versus Cimerli, which was only 3-month data. I think the biosimilars, both for ranibizumab and aflibercept, will play a huge role. In the next year, we're probably going to have 7 different biosimilars for aflibercept. So the landscape will definitely change, and already insurance companies require 2-step therapies, meaning you can start with bevacizumab, then proceed to a biosimilar, and then go with a reference product. So the landscape will change significantly in the next couple of years.
And how often do you guys use an anti-VEGF before you decide to switch to a different one?
If it doesn't work at all, 3 or 4.
Yeah, I'll usually change after 3 if no significant effect.
Any thoughts on the new 8 milligram dosing of aflibercept?
I think, Brad, I think there's potential to certainly extend the duration of aflibercept with a higher dose. And it's interesting that the higher dose did not lead to really a higher rate of complications in their trial. I am getting some patients that I can extend out on aflibercept, 14, 16 weeks. So it is exciting to see that we can extend them out, and certainly faricimab, BioVis has the same potential for extending the duration.
The notion of extended duration is not something novel, because we know, based on the extension data of U1 and U2, as Kevin just mentioned, that 50% of the patients can be maintained on 2 milligram of aflibercept every 3 months. We know, based on the extension of the Harbor, the year 2 of the Harbor trial, that with ranibizumab too, you can go up to 3 months. So I think the caveat with 8 milligram of aflibercept is that based on the Candela trial, the patients were probably undertreated, because the rescue criteria they had were, so to speak, a little bit liberal. There were not rescue criteria that represent what we do in a real life setting. For example, I think the majority of us in a real life setting will inject a patient when there is any presence of subretinal or intraretinal fluid. While in this trial, they use certain thresholds that would trigger a re-injection. These are typically thresholds that we do not follow in the clinic. So these are predetermined thresholds for trials. So there's a chance that the 8 milligram aflibercept patients were undertreated in the trial.
Do you guys feel it's ever safe to tolerate some amount of subretinal fluid?
It's hard to tell. Some patients, yes, you can tolerate it, but in some other patients, you follow them with subretinal fluid, you don't do injections, and then all of a sudden they show up with a big submacular bleed. So if we had more data to know which patients will do well and which patients you need to treat intensively, would probably feel more comfortable tolerating subretinal fluid. But yes, to answer your point, there are some patients that you can definitely tolerate subretinal fluid. I think intraretinal fluid is more detrimental for the vision, as shown in the CAT trial.
Yeah, I totally agree, Tanos. More concerned about the intraretinal fluid. At the same time, the subretinal fluid, I may not increase their frequency if it's stable, but I still want to have them on some type of regimen.
Yeah.
I would agree. Those would be ones I'd be less likely to do PRN, but certainly if you have somebody at 4 or 6 weeks that they've had the same looking fluid for 6 months or a year, 18 months, I certainly think those are reasonable to try to extend to some extent.
Any thoughts on using OCTA? Maybe Dr. Ive could answer this one about when you're treating someone and they've been dry on multiple visits, yet you're treating them for fear of reactivation. Do you use OCTA and looking at the change in morphology of the macular neovascularization to see if it appears more mature or has this pruned appearance where you kind of feel like maybe it's a little inactive?
I think that some of the studies that I've seen, particularly working with Dr. Saraf, the terminology that you described, the pruned, less kind of lacy appearance on the OCTA, kind of larger, more mature vessels can infer more quiescence to the lesions. But I have not seen clinically in Dr. Saraf's clinic here, at least, that he will make any definitive treatment decision based on the OCTA alone. So I think it still requires kind of larger experience to know for sure if it's okay to observe those types of morphologies.
Yes.
Yeah.
And kind of go ahead, Dr. Schumacher. I'm sorry.
Yeah, I find the OCTA very helpful in deciding whether to initiate treatment, much less helpful in trying to decide whether to continue the treatment exudative AMD. If it's there, the OCT is helpful, but following along for regression, I find very confusing.
Yeah. There's a question about why hasn't there been more generic or biosimilars sooner than now? It's not a silly question. It's a good question. Maybe you guys could answer that. And part of this is a run out of patents, right?
Yeah, it's the patents. The ranibizumab patent expired a few years ago. The aflibercept, it was last year, I believe, or 2 years ago. So it has to do with the patent. So there was a biosimilar ranibizumab that was marketed and still marketed in India for the last probably 5 or 6 years. It's called Razumab, but it had a very high inflammatory rate. It was about 10%. So it never found its way into the European and American market.
Yeah, as Dr. Durrani said about the bevacizumab biosimilar, you know, that was put on hold. I think it is going to come out, and I think when it comes out, it's going to change our practice patterns dramatically. I think that the compounded bevacizumab will be difficult to use once we have a quote FDA approved biosimilar.
Nice. Okay, well, I'm going to go ahead and start with the next talk. This is on retinal clues to deadly diseases. Let me pull up the slideshow here. Good. Are you guys seeing this okay?
That's great, thanks.
Yes.
Thank you. All right, so I have no financial disclosures to make. So I think one of the reasons why we all go into eye care is because you can tell so much about the systemic health of a person just by looking in the eyes. I think that's one reason why we all meet on beautiful Saturday mornings to discuss these entities. So what can we find out about the systemic health by looking in the eye? Here's a few examples. Here's a patient with bilateral ectopia lentis. And of course, the concern here is, does this patient have Marfan syndrome? And the reason why that's important is because Marfan's patients are at risk for significant health issues related to cardiac valve defects, aortic defects that can lead to sudden death. So as an eye doctor, we have the opportunity to help prevent that by making the diagnosis and working with the primary care team. Of course, we see lesions in the eye all the time that are evidence of metastatic cancers, and that is the most common cancer to the choroid. This is an example I saw in follow-up just yesterday. This patient did not know they had cancer. They were healthy. They were referred in for the evaluation of this amelanotic lesion inferior to the nerve. And after they were diagnosed with lung cancer, they received alectinib orally, and you can see good regression of this metastatic lesion. Some of the lesions we see in the eye are benign, as in these multifocal chirpy lesions that we see, but it heralds the possibility that there's colonic polyps. And in this setting, there's almost 100% rate of colorectal cancer when you see these chirpy that are associated with familial adenomatous polyposis. I'm going to concentrate this talk on based on the common causes of death as listed by the CDC. That is not yet available for 2021 and 22, but this is 2020 and 2019. And heart disease leads the list of the common causes of death by the CDC, followed by cancer. And of course, COVID made its ugly appearance in 2020. That's followed by stroke and Alzheimer's disease. I've checked the ones that we'll talk about today. The risk factors for heart disease are many, and at the top of the list is high blood pressure. And we certainly see the effects of high blood pressure in the eye. This is one of the more urgent issues where you have bilateral disc edema, heart exudates, peripapillary cotton wool spots, even subretinal fluid. And that's because their blood pressure is 180/120. When you discover these findings, you should measure the blood pressure in the office and immediately refer them to the emergency room for evaluation and treatment. Sometimes the findings of high blood pressure are very subtle. Here's an example of a patient with Elschnick spots, which indicates these pigmentary lesions in the choroid, signifying past episodes of acute elevations in high blood pressure, leading to necrosis in the choroidal vessels. There's also peripapillary cotton wool spots in this individual. Sometimes it's very subtle. You see the top panel on the right showing arteriovenous crossing changes. Sometimes you don't even see that. Sometimes it's just minimal narrowing of the arterioles. But that does constitute hypertensive retinopathy. Sometimes patients don't know they have high blood pressure, or perhaps there's a bit of denial, and maybe they don't understand the serious implications of high blood pressure. Sometimes there's elements of the conversation that go like this. Do you have high blood pressure? No. Is your blood pressure controlled? Yes. Well, what does it usually run? Well, it's good. Well, what are the numbers? Well, it's in the 140s, but I have white coat hypertension. So every time they check it, it's elevated, but that's because the doctor's wearing a white coat. Well, it's important to note that those with white coat hypertension are twice as likely to die from heart disease. Here's a patient showing this retinal thickness map that did not know she had high blood pressure. She was very healthy, had no complaints except for minimal blurred vision on the left, but the retinal thickness map shows some slight thickening temporal to the fovea. And her blood pressure was 160/105 in the office. She was immediately referred for evaluation and was begun on oral metoprolol. And on follow-up, the edema subsided somewhat. But more importantly, hopefully, as eye doctors, when we conduct these kinds of evaluations, we're helping the patient live long, healthy lives without the threat of heart disease. Note that the American Heart Association does define high blood pressure as a systolic over 130 or a diastolic pressure over 80. There's another retinal clue that we can sometimes use to help inform the patient's healthcare team, and that is central serous. Now, not the typical central serous that you see with young males who may have a type A personality or are using steroids of some sort, but those that also have concomitant sleep apnea. It's another ocular finding that we commonly see when we're looking at patients in the office with extreme lid laxity in combination with central serous. This may be a clue that they need more of a workup. Obstructive sleep apnea is of interest to cardiologists. They recognize OSA, or obstructive sleep apnea, as being potentially under-recognized throughout, and it may have implications for patients with uncontrolled or poorly or resistant hypertension. So the first take-home point is that hypertensive retinopathy, which we see every day, represents serious health disease and provides an opportunity for us eye doctors to help encourage better blood pressure control. Next on the list of the CDC for common causes of death is cancer. Now, you don't have to have a tumor in the eye to suspect metastatic disease. Here's an example of a patient who's 75 years of age and has known diabetes, complains of fatigue, and has these peripheral hemorrhages. Now, despite being diabetic, these hemorrhages are not necessarily consistent with background diabetic retinopathy. They're deeper, they're round, they're concentrated throughout the periphery, and there's a lack of venous dilation or venous tortuosity, so it's not likely to be venous stasis retinopathy or ocular ischemic syndrome. Something else needs to be done. And in this setting, with a patient complaining of fatigue and these types of hemorrhages, a CBC needs to be done. And indeed, this patient had severe anemia and was later diagnosed with chronic lymphogenous leukemia. They also had these small comma-like vessels on the conjunctiva. These have been described with leukemic patients as well. Most commonly, we see these with sickle cell patients. In contrast, there's a 19-year-old healthy male with decreased vision, otherwise felt great, but there's subretinal fluid on the B scan or the OCT of the left eye. There's blurred disc margins. Their blood pressure was elevated in the office. This patient was immediately referred for a workup of potential secondary hypertension, which led to the diagnosis of left-sided hydronephrosis. And this was due to an infiltrative lesion, which was later determined to be neuroblastoma. So in short, cancer may first present with eye manifestations other than an intraocular mass. Next is COVID-19. Now, of course, the most common eye finding with COVID is a viral conjunctivitis, as you would suspect with any viral upper respiratory infection. But there's some curious things that have been reported during the pandemic. In particular, acute macular neuroretinopathy. The report of acute macular neuroretinopathy surged during the pandemic. Curiously, a few cases were noted just prior to the COVID diagnosis. So we'll talk a little bit about that. Here you see an OCT showing some hyperreflectivity out of the outer retina. This is typically what it looks like. It can be very subtle on fundus examination. This patient presented over 10 years ago, before we knew about COVID. It's a female fighter pilot in the Air Force. And you see this reddish brown, splotchy or wedge-shaped kind of approaching onto the fovea, and they bitterly complain of central scotomas. And sometimes the lesions are very subtle. They do not leak on fluorescein angiogram. Here's another patient that was actually diagnosed with AMN shortly after developing COVID-19 symptoms with documented COVID infection. The OCT corresponds to these lesions and shows just a slight attenuation of the photoreceptors that corresponds with the findings on the near-infrared imaging. And to demonstrate the perceived pathology of acute macular neuroretinopathy, I'm showing a multicolor image, which sometimes actually documents the lesion more so than a true color fundus photograph. You can see the arrow, and I've outlined the AMN. And as I put the OCT angiogram over it, there is some reduced density of vascular flow through the chorial capillaris. So the third take-home point is COVID-related retinal manifestations are still being defined. Hopefully, as we talk about COVID, it will always be in the past tense. Now let's move on to stroke and retinal artery occlusion. You heard that this is an emergency, and indeed it is. These are the typical findings of a cherry red spot made prominent by the surrounding ischemic edema of the nerve fiber layer, given this whitening appearance on fundoscopy. Sometimes you will see a plaque, not always, but you see a plaque. In this case, part of the plaque is broken off and traveled along the inferior arteriole. There's also some segmented flow, as noted between the two arrowheads. We sometimes will refer to this as box scarring, because the blood is just slowly coming into the eye and perfusing the retinal vasculature. Related is a branch retinal artery occlusion. Here you can actually see that the embolus is probably of something different other than cholesterol, perhaps fibrin. Retinal artery occlusions can be divided into two etiologies, and that includes thromboembolic, which is by far the most common, and that can be divided from carotid arteries, usually from an atherosclerotic plaque found in the carotid arteries. Could also happen from carotid artery dissection. In some cases, it can be cardiogenic from atrial fibrillation or from a valvular abnormality, and that's why we often recommend doing an echocardiogram in addition to looking at the carotid arteries. Other findings that can cause retinal artery occlusion are less common. Giant cell can be responsible for arterial occlusion in 1 to 4% of cases. So it's important to, while evaluating these patients, determine their review systems to see if there's any polymyalgia rheumatica symptoms that may point in this direction rather than a thromboembolic source. One example is Susac syndrome as far as an inflammatory cause of retinal artery occlusion. This is an example of a Susac patient's MRI showing cotton ball lesions in the supratentorial space involving the corpus callosum. Hayray at the University of Iowa, which is Dr. Krummenacher's old stomping grounds from fellowship, demonstrated that ischemia can be irreversible, or ischemia greater than 240 minutes can cause irreversible damage to the neurosensory retina. Emboli usually appear calcific or cholesterol based, but this is based on fundoscopy. Probably in some, the emboli are posterior to the lamina cribosa and are not visible on fundoscopy. Despite calcium or cholesterol based, all major causes of thromboemboli, whether it be carotid or valvular or atrial fibrillation, are associated with at least some fibrin. And this is important to note because it plays into the potential role of treatment for artery occlusion. There's no proven treatment for arterial occlusion in the retina. There have been some anecdotal successes throughout the years, including drops, massage, paracentesis, even YAG thrombolysis has been attempted, but no proven success for these. Thrombolysis for CRAO is not a trivial procedure, and there's a high risk of hemorrhagic brain injury. That's part of the discussion we had earlier, and that's the reason why it's not done commonly. However, there are multiple studies being done. There are 3 in Europe alone looking at the newer thrombolytics. This includes tenecteplase, which is shown to have a higher Rankin score for patients treated with stroke or treated for stroke. It has a higher fibrin specificity than alteplase and a lower risk of systemic hemorrhage, as well as a higher rate of recanalization. So as we move forward with greater data, we may be able to better define who would best benefit from thrombolytic therapy. This is an example of a retrobulbar duplex ultrasound looking at retinal arterial flow. The column on the A column shows a normal patient without arterial occlusion, and column B is demonstrating a patient who presented with central retinal artery occlusion. And in B2, you can see this is showing normal or reduced flow as a result of the central retinal artery occlusion. However, after administration of thrombolytics, there is reestablishment of flow as documented by the ultrasound in panel B3. However, column C shows this white spot sign, and I've demonstrated that with an arrow, and that likely represents a greater inclusion of calcium within the embolus. C2 shows the reduced flow, and C3, despite thrombolytic therapy, shows a failure to reestablish flow. So the point in showing this is more data like this one may help us better discern which patients would be have the greatest benefit with the least amount of risk after undergoing thrombolytic therapy. I want to concentrate mostly, though, on secondary or prevention of secondary stroke. We'll look at this case. This patient had a cilioretinal artery occlusion and was treated with thrombolytic therapy. On OCT, you can see this hyperreflectivity of the nerve fiber layer, indicating the ischemia. But as Dr. Ife pointed out in his talk, we also see this paracentral acute middle maculopathy as shown by the hyperreflectivity in the deeper layers of the retina. PAM, as we'll show, is much more subtle on exam and may precede central retinal artery occlusion. Here's an example. Here's the fundus photograph showing perhaps a very subtle indication of retinal whitening approaching the fovea here. On multimodality imaging, especially with autofluorescence, we can see the hypoautofluorescence corresponding to this retinal ischemia. And on the OCT, again, you see the hyperreflectivity of the deeper layers of the retina. This is most likely due to a reduction in flow in the intermediate and deep capillary plexus, as shown by this OCT-A overlay. And I've circled the area involved again. And we see it actually more prominently on the autofluorescence. And once that's taken away, you probably can almost imagine that there is a subtle amount of retinal whitening enclosed by the circle. This does represent ischemia, and over time we can see the attenuation in the neurosensory retina. I'll show you another case. This patient complained of vague symptoms in the right eye. There was no PAM, no central retinal artery occlusion. The vessels show some attenuation of the arterioles, but as I toggle back and forth, I'm trying to show you what I saw when looking at the optic nerve, and that is some arterial pulsations. Arterial pulsations are never a normal finding. It's either because there's a reduced blood flow across the central retinal artery, or the intraocular pressure is too high. In this case, the intraocular pressure was normal. So that requires looking at the carotid arteries to see if there's an occlusion. Here are the diastole and systole photos showing greater perfusion of the central retinal artery during systole. The problem is the carotid arteries were clear in this patient, yet we know arterial pulsations are not normal. So we had to look more intracranially with a magnetic resonance angiogram. And this shows a partial blockage in the ophthalmic artery. Unfortunately, this patient went on to lose vision from neovascular glaucoma complications. So consider an urgent workup for stroke prevention. That's the primary reason why where we should focus our treatment when we see patients with ischemia in the retina. And that might include profound retinal whitening as seen as in a central retinal artery occlusion, or more subtle findings as seen in paracentral acute middle maculopathy. Arterial pulsations are an uncommon finding, but if you see that, it is abnormal and demands a workup. We didn't talk about amaurosis fugax, but this still needs an urgent workup for secondary stroke prevention, even when there's no retinal findings at all. An urgent CTA or MRA of the head and neck is required, or at least a duplex ultrasound of carotids, and then an echocardiogram as well to look for valvular abnormalities or mural wall thrombus in atrial fibrillation. Important thing is you must communicate with the emergency room doctor. Head imaging will be normal, that is, until a stroke occurs. So the reason for sending them to the ER is not to diagnose a stroke, it's to prevent a stroke. So we're looking for pathology that would lead to stroke after the fact. So the take-home point for this one is that vascular occlusion may herald impending stroke and requires immediate intervention or evaluation for possible intervention. We'll look at Alzheimer's disease as well. There is some interest in looking at OCT findings in an effort to assist neurologists in making this diagnosis. This is the most common cause of cognitive decline, and unfortunately the diagnosis cannot be made definitively unless tissue is obtained in the form of a biopsy or autopsy. The findings are mixed. Researchers are looking at thinning of the nerve fiber layer, the ganglion cell interplexiform layer. Overall macular thickness and volume is being evaluated, as well as choroidal thickness, and even flow via OCT angiogram is being looked at as a possible precursor for Alzheimer's disease. This is an area, as Dr. Ife mentioned earlier, where machine learning or deep learning and artificial intelligence are likely to be necessary in helping us make this diagnosis for our neurology colleagues. Here's a patient, or here's 4 patients that I saw in one day. They're all between the ages of 65 and 70. They're all females. They all have asymptomatic left eyes. I'm showing the retinal thickness of each, and in the top left, that patient has known Alzheimer's disease and is being treated with Aricept. The patients in the second column on the right, when you compare these, they appear to have a thicker overall retinal thickness. But the question is, what about the one on the bottom left? It seems to be a little thinner, and it shows the problem. We can't predict this patient will have Alzheimer's. There's no way of looking at this one parameter. And that's why it will be important to look at hundreds to thousands of parameters and feeding this to a machine, and utilizing 250,000 patients or more to teach a machine how to pick up on these subtle differences. And hopefully one day it will be helpful in documenting patients that are likely to develop Alzheimer's, and maybe even more importantly, prevent it with earlier treatment. So take-home point for this is that OCT findings may prove useful in aiding the diagnosis of Alzheimer's disease. So in conclusion, eyes provide windows into systemic health, and we have the opportunity to help patients beyond just taking care of their vision. And with that, entertain any questions or comments, or if anybody else wants to make some comments, great.
Brad, great job as always. There was a question earlier that I think we partially addressed about interchamber paracentesis. If you want to address that for CRAOs.
Yeah, and I think we're all want to help these patients when they come in. It's a terrible loss of vision, and I don't routinely perform AC paracentesis. The thought is maybe you can acutely decrease the pressure in the eye and possibly help move the embolus downstream a bit to maybe decrease the area of the retina affected by the ischemia. I have seen success with it, and I know each of you have probably seen some success with it, but I don't routinely perform it. What about the other members of the panelist?
I saw a lady, she was shopping at the Galleria, and she had a central retinal artery occlusion, came across the street, and within an hour, I did a paracentesis and ocular massage, and it didn't help.
I do it occasionally. You know, I've gotten some mixed results over the years, but the time it really helped was when I was an intern in the ICU, cardiac ICU, and a patient lost vision suddenly. And me and another intern that were going into ophthalmology performed ocular massage and actually brought the vision back. So that's anecdotal. We didn't have a fluorescein in the ICU, but you know, that's what we thought was going on.
That mentioning of the fluorescein, I think is important. That kind of reminds me to speak about the problems with developing a protocol for intra-arterial thrombolytic therapy. For that, you need an interventional neuroradiologist to perform the treatment. And also, ideally, you need an ophthalmologist in the suite, occasionally looking at the eye to determine whether or not flow has been reestablished. For intra-arterial delivery, you want to give this in small pulses, and you certainly don't want to treat too much because of the high risk of hemorrhagic brain injury. You want to give just enough to recanalize the central retinal artery occlusion. And on the opposite side, you don't want to put the patient at risk by canalizing their ophthalmic artery and then undertreat them with a single dose of thrombolytic therapy after you just put them at risk, where you could have maybe with a couple more pulses of thrombolytics opened that arterial. So that's one of the problems with the protocol. Again, there's a few places here in St. Louis that will administer IV thrombolytic therapy. But again, they really have to be at the ER within 4.5 hours and have no evidence of hemorrhage in the brain. And it's a significant risk. Again, calcium and cholesterol-based plaques probably won't respond. It's only the fibrin-based plaques that would respond to it. But hopefully one of these days we can better develop a protocol and know who would respond to it without putting them at significant risk.
Dr. Smith, when you see one of these patients that was, they're otherwise a young, healthy person that has a problem that you catch when you're looking in the eyes, and they were referred and they don't have a primary care doctor, how do you go about, when do you decide that they should go to like an urgent care and emergency room versus try and establish with a primary care? Because those can be difficult to get an appointment within, you know, even a month. Yeah,
I know you and all of us have experienced that. I mean, part of the reason why they don't have a primary care doctor is because they think they're healthy. And if I can't get a hold of someone to establish some care or be convinced that they fully understand the implications of what we're seeing in the eye, then I will send them to the emergency room.
Yeah, I agree, Brad. My threshold at some the emergency room is very low. In the past, we used to try to do this as outpatient, even if they haven't established internist. I think the workup is too slow many times.
I think like all of us in healthcare, our primary care colleagues are just at their limits seeing patients. I mean, the patients just keep coming and coming and coming. So it's hard to ask them to, add on to their busy schedules to take care of patients. We're blessed with a lot of great physicians here in St. Louis, and as well as our colleagues online with us today in the eye care community. But the resources seem to get thinner and thinner.
One other comment I'd like to make just about central retinal artery occlusions. Just from recent experience, there was a lady in her 80s who presented to the urgent care that's available at UCLA, and she was found to have a central retinal artery occlusion, was sent to the emergency room for workup and evaluation of stroke. They did end up getting ESR and CRP, but didn't act on the elevated levels because she reported a history of rheumatoid arthritis. So just want to also mention and have everyone keep in mind giant cell arteritis as a potential cause, underlying etiology of central retinal artery occlusion, and to be sure to follow up and perhaps request rheumatologic evaluation or consultation for any patient who goes to the emergency room, doesn't find stroke is the right age group. This patient also didn't have any typical giant cell symptoms, but when she presented back to the clinic a week or so later, vision was still getting worse, and we saw that the ESR was elevated and actually initiated with the oculoplastics team to do temporal artery biopsy, and it in fact showed active arteritis. So she was readmitted to the hospital and treated with steroids. So just to keep that in mind too, that the underlying etiology may not be stroke or embolic, but could be inflammatory in that way.
Yeah, exactly.
Great point. I know to the ER physician, if I can't talk to them directly, I always say, draw an ESR and C-reactive protein. So great point, Nick.
There's a question about reducing the intraocular pressure. We somewhat touched on that with ocular massage and AC paracentesis. I have given these patients prescriptions for brimonidine to use 3 times a day. I mean, it feels like such a homeopathic way of treating it, and it certainly does not negate the need for workup to prevent stroke. But the thought is maybe could lower the pressure a little bit, maybe help tip the scales a little bit in their favor. And there was old data, from the glaucoma literature suggesting that brimonidine may have some neuroprotective effects. But again, it's an anecdotal thing. Okay, well, with that, we'll move on to our final talk given by Dr. Honosage, who will be speaking about epiretinal membranes.
All right, thanks everyone for sticking around. For the next few months, I'm still the new guy. I'm Avinash. I've met many of you before. I've been around St. Louis for some time. I'm going to talk about something a little less deadly and a little more surgical today, epiretinal membranes, no financial disclosures. So a brief history, this was originally described in the 1860s as a proliferation of tissue over the retina, which is still an accurate description. In the 80s, Dr. Gass, who's one of the retina pioneers, came up with a staging system based off of his view of the retina. Now we have better technology to kind of get a microscopic assessment for what's going on. And then in the 90s, we started doing surgery for holes in membranes. So what is an ERM? Most of the time, it's made out of hyelocytes, which are cells that are in the vitreous body, and glial cells, which are support cells in the nervous system. One of the questions is, why does it grow on certain retinas and not in others? And that's not entirely clear. Sometimes you can also have retinal pigment epithelial cells that are released, especially if you've had a tear, a hole, or a detachment. Those can settle and layer onto the posterior pole, and you can get proliferative vitreoretinopathy, which can look very similar. This is an example of Dr. Gass's staging system with something he deemed cellophane retinopathy as stage A, then crinkled cellophane retinopathy as stage B, and then you can have something he called a macular pucker, which is why we use all of these terms to this day as stage C. sometimes when you see these, if you're looking in, it looks like there's a hole right in the center because the fovea is a little more spared than the macula around it with this membrane. And so you can get this pseudo hole appearance. Nowadays, we use OCT more to define stages. But even here, stage 1 would be with a fovea intact, and then you could lose the fovea, and then progressively you lose the definition of the different layers of the retina. But I do want to emphasize even here, it's not necessarily how it looks, it's really how the patient feels about this. So this patient can be completely miserable at 20/20, and this patient can be totally happy at 20/30, and this patient can have mild symptoms at 20/50. This patient has their non-dominant eye with this and never noticed a problem, and were just incidentally sent in to see us. So who gets ERM? Well, they're very common. You can catch it on about 10% of OCTs, and it's often bilateral. We categorize a lot of them as idiopathic, but really that just probably means we don't know the cause, but there is a cause, and it's something undiagnosed or not yet discovered. Vascular disease can certainly cause this and mimic this as well. This is an example on the right of a patient I had with Dr. Shaw. This patient had a retinal vein occlusion and an epiretinal membrane, and with removing of the traction from the membrane, the swelling from the vein occlusion collapsed. Inflammatory disease, intraocular tumors can also cause membranes, and then retinal tears and detachments or any intraocular surgery can kind of start this in motion. On the differential, if you get, for instance, a fluorescein of an ERM, you could see leakage sometimes, and you can see leakage in other diseases. So there are other things to look for that look like ERM or may be in tandem with ERM. The chief complaint that most people have with ERMs is a blur that's not correctable by glasses or contacts. Diplopia, especially monocular, is common. You can even get binocular diplopia if you have a shifting of the fovea, if it stretches and it's a true macular pucker, I guess, as Dr. Gass would call it. You can have distortions and micropsia. As the membrane grows, it pulls the photoreceptors apart, which the brain interprets as smaller images. And then it could actually lead to a full-on macular hole if it stretches the fovea far enough. Things to look for, though, and be concerned about. Most epiretinal membranes, as Dr. Dang mentioned in his talk, are not emergencies. And even these are not necessarily emergencies, but there is probably some urgency and something that may be missed during the diagnosis. If there's a rapidly progressive ERM over days or weeks or even a few months rather than over 6 months to a year or a couple of years, there may be an undiagnosed retinal tear, retinal detachment, that sort of thing. Tortuous vessels can also be an indicator that there is a vein occlusion that's been undiagnosed. And then disrupted retinal architecture. This picture here is a more extreme example, but there is an ERM. There's a white line overlying the retina. But then in addition to that, there's also some subretinal fluid here. This patient had, as you can see on the face, on FOS-OCT, an inferior detachment. And keep this patient in mind. We're going to show some pictures of her later. So when do you operate? Well, it really most of the time comes down to symptoms. Symptomology drives ERM peel. It is truly an elective surgery that we do. But some patients say, you know, I have some blur. How much is a reasonable amount? And this varies depending on the surgeon and the patient, but 20/40 is a reasonable cutoff that some people use that say, if it's worse than that, there's a good chance we can improve you enough that you notice a difference with surgery. And below that, you may not notice too much of a difference with surgery. You could also certainly try medically managing these first, updating a glasses prescription or a contact lens prescription. You can trial, especially in the presence of macular edema. You could try steroids or non-steroidal anti-inflammatory drops to see if that can reduce part of the issue. Sometimes it is difficult, like Dr. Dang again mentioned in his talk, to kind of discern whether this is this DME or is this an epiretinal membrane intraction. And the only real way to kind of tease that out is to treat one and see if the other one improves. The rate of progression of these is generally slow. You could always or you can almost always wait on these and have them come back in 6 months or a year if they're not sure, or if you're not sure. And if it's growing, you can refer them. And we often, especially with a first visit with a patient who has some kind of mild blur, watch it and kind of establish care before we talk about surgery. Another question a lot of people have is whether you should get the cataract removed. There are certainly a few benefits to removing cataracts before membrane surgery. The biggest one being you may get them below a threshold of vision complaints where it fixes their problem and they're happy. It's easier for us to do surgery too. It's easier to view the membrane with a clear lens versus a cloudy lens. And removing the cataract can give access to the anterior vitreous floaters that might otherwise be left there if they have the membrane peeled first. Reasons to be more aggressive with membrane surgery would include if you see a retinal tear or detachment, then you might want to jump to the operating room a little sooner. You want to be careful with patients that have symptoms that are out of proportion to their ERM. So if they have a mild membrane, but a lot of symptoms, there may be something else going on, a corneal or cataract pathology. The ERM, the OCT really does give a pretty good prognosis as to how well they should be seeing and how well they will see after, and we'll talk about that in a second. If you see even a hint of an ERM, you want to be cautious using multifocal lenses. These can grow, and in those patients, they're among the most difficult to make happy because the multifocal lens plays poorly with the twisted retina, and even with a peel, the retina doesn't always go back to a totally normal architecture, and those patients can often end up with monocular diplopia. On the right here are some concomitant pathologies that can go with ERM. The top one's a pretty standard ERM. The next one shows a lamellar hole, and then you can see this hyporeflective ERM. This is known as LHEP, or a lamellar hole with epiretinal proliferation. These, even if you peel the membrane, sometimes the hole doesn't close. It's not like a macular hole surgery. The membrane is gummy. Thankfully, these patients are generally less symptomatic and have better vision than a macular hole. And then below that, you have schisis of the fovea or the macula. This is especially common in patients that have high myopia. The surgery is a bit more difficult. The reach is longer, but also by peeling away this membrane, you may not necessarily collapse that schisis cavity. So prognostic factors, there is a lot of research going into what signs, especially on OCT, which is a great way to view an ERM, what signs suggest poor prognosis. And you can see in this top figure, there's something they're calling foveal herniation. The fovea is actually piercing through the epiretinal membrane centrally, and that amount of distortion is usually associated with a poor prognosis afterwards. Down below, this is a vitreomacular traction picture, but even in figure C here, you can see a smaller version, something called the cotton ball sign. It's a disruption of that outer retinal architecture, and those photoreceptors also seems to be a poor prognosis, where even if you release the membrane traction, they may have some long-term permanent disruption. There may be a role also for OCTA here. OCTA can show the vasculature, which can be compromised by the ERM, and the thought may be that the ERM is preventing good blood flow to the retina. And then with peeling, you can see a restoration of a normal foveal avascular zone and normal vasculature around. I shamelessly stole this analogy from someone. It might be Dr. Grand or Dr. Shaw, someone at the practice. But basically, when I talk to patients about ERMs, I tell them if a normal retina is like a clean sheet of paper, and this is obviously an exaggeration, but the retina is like a crumpled sheet of paper, and by doing surgery, it smooths out the crumpling, but it doesn't restore a totally normal architecture. And we'll show some examples of that here. So the general steps for the surgery are enter the eye, take out the vitreous, and if there's a vitreous attachment, lift the vitreous away, and then stain the membrane. There's many different dyes. Some people don't use stain as well. That's an option. And this is the internal limiting membrane. This is the innermost layer of the retina that's just below the epiretinal membrane and gives you a good idea for where there is and is not ERM. you peel away the membranes, and there's different ways to do that, and then look around and see if there are any, hidden tears that could explain this or any other pathology. So this is a patient I saw with Dr. Shaw. This patient has, her complaint was she had a hair-like line in her vision, and she had blur, and sure enough, there's this hair coming off this ERM. It looks like it might have been partially avulsed by her vitreous detachment. And it's just floating parafoveally there. And so this is a good candidate to do surgery. This surgery here, I'm going to pause for a second. This, the vitreous has been largely removed. The internal limiting membrane has been stained, and a portion of the ILM has been peeled. And so you can see these three different zones here. In the blue is where the ILM is present. In the clear area here, there's no ILM or ERM. And over here with this kind of speckled appearance, there is some ERM that still remains. And so the goal is to try and peel this. And the strategy is similar to a capsulorhexis for cataract surgery. You kind of want to get a couple of disc diameters around the fovea to clear out that epiretinal membrane. And that's how this looks here. And so we've worked our way around and we're peeling away the membrane. And this patient ended up being very happy. And her hair-like line went away and her blur lightened up, and she was happy with the outcome. This is another example. This patient has an ERM, true, but it's also this combo with vitreomacular traction and an intact hyaloid, and this patient had blur as well. So in this case, we had to actually lift the hyaloid, and you can see here it's stained with Kenalog, and it's popping off the posterior vitreous. And then after we did that, we had to go, this stain is a little lighter in part because there was a more diffuse sheet of ERM. So it was, there weren't kind of clear islands of ERM and then stained ILM. This patient also ended up happy, but you can see the architecture never fully recovered. He didn't regain his foveal depression, but he still was happy with the outcome. And this is kind of the other end, the more extreme end of the spectrum. This is a patient I saw with Dr. Engelbrecht. This patient had a count fingers epiretinal membrane. And if you have something like that, and his pre-op complaint was a dark circle with bright edges around it, basically he could see a scotoma from his ERM, which prepares you for what Dr. Gass would classify as a pucker. This is going to be a more extreme taut membrane, and actually required we had to make a plane by actually using a needle to prick into it because we couldn't even use the forceps to make a dent to start. But you can see here as this one's being peeled, it is so tautly adherent to the retina underneath it that it's pulling the retina as it's going. And this patient ended up also doing quite well. That scotoma, that dark area went away. The architecture improved, but obviously isn't totally normal. This patient also has diabetes and diabetic retinopathy, and his vision was much better than pre-op. And to get back to that lady who had the detachment to go along with her ERM, the membrane can be peeled during detachment surgery. It's sort of a moving target because the membrane sits over this, in this case, MAC off detachment, and peeling that membrane can be a little more difficult, but she is doing well, and I'm actually removing her oil on Tuesday, and hopefully all goes well. So how do these patients do? They fare generally pretty well. Most patients improve, their vision improves. This is a recent study showing that improvement can go on for years. They found continued improvement in these idiopathic ERMs for up to 3 years after surgery. I usually quote patients about 12 months. The first couple, this is not like cataract surgery with such a rapid recovery of vision. The retina architecture continues to mold and change over time. The patients that have worse pre-op vision end up largely with worse post-op vision, but a bigger gain than the patients that are closer to 20/20. The gains generally also seem sustained long-term, which is good, and there's a very low risk for recurrence. There is a question of whether it makes sense to peel that internal limiting membrane. You're literally ripping off a portion of the retina and the end feet of these Mueller glia. And the question is, are you causing more harm than good? The data out there, there are data to support both ways. I think most people do remove ILM. It does seem to reduce recurrence. The vision doesn't necessarily improve from that ILM peel, however. So in conclusion, not all ERMs are equal. There are some that are standard run-of-the-mill ERMs, and there are some that are secondary to retinal tears, retinal detachments. And this is a symptomatically driven surgery for the most part, unless, like I mentioned, they have something else that needs more urgent surgery. And so if the patient is asymptomatic, it's usually best to leave it alone until they become symptomatic. And even if they are symptomatic, it's usually best to try medically managing first with, a glasses prescription or cataract surgery. See if you can get them happy. There are risks with surgery. This is one of the more routine surgeries we do. Generally, patients end up happy after the surgery. They say, yeah, my vision isn't as good as perhaps the eye that has a normal retinal contour, but they're glad they did it. The distortion has lessened, the blur has lessened. And if you see an aggressive ERM, especially one that creeps up over the last few weeks or a couple of months rather than over years, be wary because it suggests that there's something else going on. My email address is down at the bottom. I'm happy to take any questions. Thank you guys for taking a listen.
Wonderful talk, Dr. Hanasagi. There's a question, and I pose it to you and the rest of the panelists as well. Do you see retinal thinning after removing the epiretinal membrane? And maybe do you notice it more if you remove the internal limiting membrane as well?
Yes, you do see thinning of the retina after removing the ILM. It's always hard to tell if that's visually significant because you don't have a control of doing that same surgery on the patient without removing ILM. The foveal contour can be quite irregular after removing the ILM, but generally, even with a well-seeing eye, a 20/30 ERM, removing the ILM seems to improve their vision long-term, at least in what I've seen. So I always remove ILM when I remove ERM.
Avi, great job as always. Wonderful to have you on board. Star fellow that's gone on to be an attending. We're very happy to have you. Question is, do you think the timing of surgery is important with macular puckers? And I ask that because, as you know, we're doing the DRCR-AM trial looking at the timing of intervention, early intervention versus delayed intervention. Do you think that's important?
That's a great question. I guess hopefully the trial helps elucidate this. Most studies that I've seen, they're not a prospective study like that DRCR trial, show that you can wait on it, especially kind of a moderate ERM without rapidity or aggression. Seems like something you can wait on, have the patient come back, perhaps get them pseudophakic beforehand, and they seem to do well. But hopefully that trial, I'm glad you mentioned it, will tell us if early intervention here is going to be helpful long-term or not.
I think macular surgery is one of the most fun things that we do, most exciting things that we do, and very helpful for patients. Curious for the panelists, though, how often do you have patients that come in that definitely have an epiretinal membrane? The OCT is showing a fairly prominent membrane, but you get the sense in talking with the patient that they're not necessarily bothered by distortion or even unilateral vision complaint. It's more of a vague complaint, maybe dry eye syndrome, maybe a combination of dry eye syndrome with presbyopic symptoms. How do you tease that out with your patients and decide who is the best surgical candidate?
Amsar grid may help.
Yeah, I think that's a fairly common scenario that we are sent patients with an abnormal OCT and patient didn't know anything was wrong, or they still don't seem to be bothered by it while you're talking to them about it. So those are the ones certainly to hesitate with.
Yeah, I agree. That's why for the study we're recruiting for, it's very difficult because some patients come in, they have a significant pucker, and you say, "Oh, you'd be a great candidate for the trial," and they say, "Well, nothing's wrong with my eye. Why would I have be entering a trial that I might have to have surgery?" So it's amazing the variety of symptomatology in these pucker patients. Other patients come in with 20/20 eye and a mild pucker, and they're distraught with the metamorphopsia.
It's amazing how smart patients can be.
I agree with all the comments. I usually go by the metamorphopsia, not so much based on the visual acuity, because as Kevin mentioned, you can be 20/25 and you can have metamorphopsia that is significant enough to create problems for you, or you can be 20/40 or 20/50 and you might not complain about anything. So I usually go by the metamorphopsia. The DRCR trial is going to be looking into that with the M-charts, which is a special test that checks for metamorphopsia. We usually don't do these things in the clinic, unfortunately, because they're time consuming and they require some training. I usually counsel patients that don't get fixated so much on the numbers of the visual acuity, but let's go more by the symptoms. So if your metamorphopsia will improve after the surgery.
It's a good question from the audience about how often do you see an epiretinal membrane resolve on its own?
Sometimes.
Yeah.
I think it's fairly rare. If it's associated with vitriomacular traction, then there's an opportunity for that. But otherwise, I think it's unlikely it's going to go away on its own.
Yeah, I agree. I think it's rare. It's rare. I think the studies have shown probably less than 10%. I have one patient that it was wonderful. A friend of the family, of course, came in and had spontaneous separation of the pucker, and it just sits there right over the macula. So still symptomatic, but a less metamorphopsia.
Yeah. I think as Dr. Engelbrecht alluded to, if the hyaloid is down, the hyaloid could do your peel for you as it lifts.
Yeah.
And we see that sometimes intraoperatively where we lift the hyaloid and you stain and then it's already halfway up. Makes it much easier. I think one of the other scenarios to talk about is the scenario where people have edema associated with either diabetes or vein occlusion and an ERM, and trying to make the determination of is surgery appropriate or not with the underlying condition. And I'm sure you've seen that sometimes you can significantly reduce the treatment burden or even get rid of doing injections. If you're doing injections for edema associated with those and then do the peel, that may at least let you spread them out or be able to stop them all together because the edema then resolves as well.
Yeah, that's exactly right. I showed that one picture of the patient with the RVO, significant edema in the ERM, and it collapsed. Dr. Shaw always said, you're taking a combined surgical and medical problem and turning it into a purely medical problem by fixing the membrane. You've kind of isolated the problem in that sense.
But your point also was good about making sure the periphery is free of any retinal tears. We see upwards of 10 to 15% incidence of retinal tears when an epiretinal membrane is present. So that's a good take-home point to carefully scleral depress the peripheral retina to make sure there's no tear. All right, well, there's one more question popping up. Okay, here, this is from an earlier talk, perhaps. There was a comment made earlier about a case of neovascular glaucoma without retinal neovascularization. Can you talk more about how this is possible? Certainly you can have anterior segment ischemia in a variety of cases and have neovascularization located to the anterior segment. And it may be a watershed zone. It may be more often found with ocular ischemic syndrome, but it can be found with retinal artery occlusions and vein occlusions as well, and diabetes. Any comments from the panelists on that?
I think that's a scenario where, sorry, Kevin, and particularly in diabetics, that the fundus exam may be fairly unremarkable and you do a wide field angiography, and it's really impressive how much ischemia they have that isn't obvious on just the clinical exam.
I think
You can
another,
have, an ischemic CRVO with anterior segment neovascularization. That's a pretty common scenario.
Yeah, and we published a case report years ago of just a diabetic with no diabetic retinopathy with iris neovascularization. So the reason why to look at the iris in all our diabetics.
yeah. I would also add to that, that if you have a patient that you're following with diabetic retinopathy, even in the absence of severe retinopathy or macular edema or neovascularization or iris neovascularization, if their pressure is high, that really needs to be evaluated further. Don't trust it. Don't write it off as saying, well, it's the bad tonopen this time. Recheck it with applanation. And if it is indeed high, they really need to have gonioscopy to evaluate the angle, because sometimes patients can present with neovascularization in the angle even before it's observed on the iris or anywhere else.
Brad, an unrelated question was the significance of tobacco dust in the presence of a PVD. So I assume if there's tobacco dust, then there has to be a break.
Well, I agree, Kim. I think there's a high correlation, and that was Dr. Holkamp's question about Ed Bouldry's paper, with the pepper dot floaters or diffuse floaters, tobacco dusting, and blood in the eye. So certainly all those are significant clues to indicate a much higher incidence of retinal tears. So I agree. I think it's a tear until proven otherwise.
Yeah, I think it's like a 70% incidence if you see Schaefer sign or pigment in the anterior vitreous. OCTs are so commonly performed now that even looking at an OCT in a patient with PVD symptoms, oftentimes you can see vitreous opacities on that macular OCT. If you see that, really look at the periphery or consider referring them if you don't feel comfortable looking at the periphery to make sure there's no retinal tear. Good questions. Okay, let's move on to the case discussions. So I will start the screen here. Okay, you should be able to see my slideshow now. So this is one of the favorite parts of the meeting where we're just going to have a free-form discussion as cases come into the retinal office. And so can you see my screen okay?
Yes.
All right, here's the first patient. This is a 24-year-old female with blurred vision, severe headache, and optic nerve swelling. And this is what they look like on fundus examination. What are your thoughts? Dr. Ingray, you want to take this one?
Sure. So obviously colored fundus photos of each eye. The right eye shows optic disc edema as described in the clinical update or the clinical history. Vasculature appears pretty symmetric. There's some pallor of the macula, but no hemorrhage there. No hemorrhage is seen on in the periphery. And the left eye optic disc is sharp and pink. The macula vasculature all look fairly normal.
Would any of you guys do any additional testing in the office to help you discern what's going on here?
OCT?
Yeah, so that, I guess it confirms the macular edema and the subretinal fluid associated with the nerve swelling. Dr. Eve, what do you think now? Would you do anything else with this, or?
Well, initially with just the optic disc edema without this photo, considering the differential of unilateral optic disc edema with compressive lesions or ischemic optic neuropathy, inflammatory and infectious processes. That's where I would start. Now with the OCT and the macular thickening, neuroretinitis seems like a more likely candidate, although that OCT looks exactly like the OCT you showed from your previous presentation with the hypertensive case of the 19-year-old. So we also need to check the blood pressure while they're in the office too. But then certainly a lab workup. At 24, they aren't going to have giant cells, so I wouldn't chase that. More likely to have ischemic optic neuropathy either. But certainly consideration when looking at imaging for a compressive lesion with complaint of a headache. And then lab workup I would include CBC. Look for syphilis, Lyme disease, toxoplasmosis, and Bartonella.
Yeah, I think that's excellent points. This patient did have some imaging, and it showed some head imaging to rule out a compressive lesion given the focal headache, but it showed sinus disease. That's all it showed. And fortunately, or maybe unfortunately, the patient underwent this urgent endoscopic surgery and was discharged on Augmentin. Is that the end of the story? Would you call it there and say, hey, the sinus disease is cured, the vision 2100, 20 or 1200, maybe that's okay. Maybe we found the problem.
I'd like to see the results of the other labs.
Okay. Yeah. So good. Yeah. So this patient's Bartonella came back positive, and they were started on doxycycline. How often do you guys see Bartonella neuroretinitis without a definitive macular star, as is classically shown in textbooks?
You see it all the time because the macular star doesn't show up until weeks later when the subretinal fluid resolves.
Yeah.
Does she have a cat?
She does. Yeah.
Is it a mean cat?
There's no mean cats, right? They're all nice. But it wasn't exactly disclosed that she had a cat. In fact, she doesn't have a cat, but in follow-up, when the Bartonella came back positive, we were able to elicit that, oh, there was a visit to a friend who had a cat. So you don't have to have a cat, you just have to have a friend who has a cat. You can see that macular star forming and then subsequently resolving. The OCT showed that initial edema with visual acuity 1/200 and then improving to 20/90, and then ultimately back to 20/40 with full resolution of the optic nerve head edema. Any other thoughts from the panelists before we move on to the next case?
Now, Brad, I thought that there was no conclusive proof that antibiotics helped because it usually goes away by itself. So is there any definitive proof about what therapy is the best? I always treat mine with doxy, but they all get better, and I obviously take credit for it, but I'm not sure if there's any true proof that antibiotics help hasten or improve the outcome.
That is a teaching that it will self-resolve, but I've never been comfortable watching somebody with 1/200 vision and nerve edema. The one thing I would say is that multiple antibiotics can treat Bartonella, with one exception, and that is Augmentin. So even though this patient was placed on an antibiotic, that would not necessarily treat a cat scratch disease.
You did Bartonella IgG, IgM?
That's right. What, has anyone ever had a neuroretinitis patient that you just watched?
No, I've always treated them. The risk from the antibiotics is quite low, and there are Bartonella cases reported in the literature that the vision was quite poor after the acute event went away. So I always favor treatment.
The last patient I had, by the time the serology was returned, he was getting better.
Oh, really? Yeah, interesting. Okay, here's another case, case number 2. 45-year-old glaucoma patient with progressive peripheral field loss and high pressure. Dr. Honasagi, would you mind taking on this one?
Sure. This is a, excuse me, a fundus photo of the left eye. The disc does appear to have some cupping. The vasculature temporally looks normal, nasally looks a little darkened, and the attention is drawn to what looks like the superior macula, and then supranasally there's a loss of choroidal detail there. There also looks like there might be a pigment demarcation line infranasally, and then there's this big what looks like a retinal or subretinal clearish translucent mass supranasally as well. The pressure is up indeed, and the vision is down. I would want to get an OCT through the macula and see if there's any fluid in there, and perhaps peripherally as well, to assess if there is fluid where there's loss of choroidal detail.
This is a vertical OCT through the macula. Does that help you?
Yeah, this looks like a full thickness detachment of the neurosensory retina. It looks like a superior retinal detachment that's spilled into the macula, which makes me more suspicious that that translucent mass up top is a retinal cyst. And here's a cut through the edge of that cyst, it looks like. And then could explain the elevated pressure as well from released photoreceptors lodging into the trabecular meshwork. So this patient needs surgery.
Yeah.
Unless that it didn't look like that pigmentation line worked its way all the way, and there's fluid in the macula, so I'd recommend surgery for this patient.
Yeah, indeed. Yeah, good. This is kind of very subtle. I think the Optos maybe highlights it a little bit more than what you would see on fundus examination. But certainly when you see that wide field imaging, you get an appreciation of the macro cyst. How do you explain the ocular hypertension in the setting of a detachment like this? Usually when we see an acute detachment, we see a low intraocular pressure.
Right. So my understanding from the Schwartz-Matsuo syndrome is that photoreceptors are released and then they lodge into the drainage system, and that clogs things up, which could lead to a high eye pressure.
Yeah. I'm just showing a ultrasound biomicroscopy. This is a different patient. You really can't see photoreceptors on UBMs, but just demonstrating that really anterior, anything in the anterior segment can clog the trabecular meshwork, whether it be white blood cells or hemorrhage, or as you said, potential outer segments of the photoreceptors clogging the trabecular meshwork. These macrocysts are often very prominent. Here's another patient on ultrasound of the posterior segment where you see multiple macrocysts. This patient had a chronic retinal detachment and a history of getting kicked in the head multiple times. That'll do it.
I think, Brad, your point of acute detachments with low pressure, I think is important. I had a resident check out to me in clinic one day, and the diagnosis was primary ocular hypotony. And I said, well, that's funny. I've never heard of that. And did you dilate the patient? Oh, do you think I should? And sure enough, it was an acute detachment. So when in doubt, dilate.
Or look for the hole in the side of the sclera.
Right. That's right.
So Brad, how about the timing of if you go back to the OCT, the timing of surgery for this patient? There's obviously chronicity there, but they're more recently symptomatic. Was this, and the fovea is essentially split there, I'd say right to the fovea at least. Was this a urgent 24 hours within the 24-hour case, although it looks like it's chronic, or was this I'm assuming there's some recent extension? How quickly was this repaired?
I didn't take them to the operating room that night, but they're coming in complaining of decreased vision. They got a problem that we're seeing. I think I took them to the operating room within a day or two. I don't know. What would you guys do?
I would do the same thing as you did. Yeah, it's a chronic detachment. Of course, we can go by the chronicity here and say we're going to operate, next week or in 2 weeks because the fovea is threatened. But yes, within a day or two, I think it's the best course of action.
Yeah.
You also mentioned this is a young person. It looks like the hyaloid might be down as well, which that vitreous acts as a better tamponade than if they've had a PVD. So there's a little more time too.
Yeah. Bringing up points, these patients, whether they're MAC on or MAC off, they have a problem. They're complaining of vision loss. How often do you guys have it enter into your mind the possibility of not a medical issue, but a medical legal issue? God forbid they don't have a great outcome, and for whatever reason, not because of anyone's fault, it's just the problem with dealing with retinal pathology. Sometimes the vision just doesn't come back. Does that Does that enter into your mind at all when you're thinking about the timing of these repairs?
I think it does if you go weeks instead of days.
Yeah.
I think we're all, advocates of our patients, and we want to do the best job we can for them. And, I think we have a certain criteria that we go by, and we do the best we can.
Yeah. What about glaucoma? Do you think there is an element of glaucoma, or is this simply just ocular hypertension secondary to the chronic detachment?
This is one thing that I mentioned before I did want to comment on. The fundus photo does appear to show some cupping there. But interestingly, if you look at the OCT-B scan above, the green line that's apparently supposed to be highlighting the outer edge of the nerve fiber layer, in this area of thinning kind of centrally in the photo, the green line kind of jumps up very close to the red line. And I would be suspicious that this is incorrect segmentation from the device. If you look where it starts to kind of diverge the normal path, there is no real demarcation from the RNFL. So I think it's an artifactual presentation of it being thin in that area, possibly due to the shift of the retina from the other atrophy that's occurring. But I'm not sure the RNFL in this case is necessarily thin.
I agree, Nick. I also think if you look at the actual measurements in that circle on the left, the supranasal and nasal measurements are below the floor of what is left after you lose all of your ganglion cells. So you basically, you should still have 50-ish microns of retina left, and those say that it's below, and even at the line on the bottom, it's dropped down to 0 in a couple of places. So it is probably improper segmentation, or it's been thrown off by the retinal detachment supranasally. So this patient may have glaucoma, but I think they have a bigger issue right now.
Those are excellent points. I'm glad you brought those up. Looking at the nerve fiber layer just on the B scan, though, you get the sense that it's pretty robust, even in the nasal retina, right? But there is significant absence of the outer retina, including the photoreceptors and external limiting membrane. Do you think there's a chance the temporal vision can return based on this OCT?
I think by fixing the detachment, you give it the best chance. As we see with the presentation on epiretinal membranes, we know the retina does remodel with time. So by fixing the attachment, reapproximating the retina to improve blood flow and nutrients from the choroid, I think that gives it the best chance. And I think patients do probably experience slow improvements in vision, even years or so after repair of retinal detachments. And that's something that I like to counsel my patients on who have acute detachments, that, we want to restore vision and improve anatomy as a primary marker, but the function is a secondary marker as well. And that takes a little bit more time to recover.
I think there's a higher chance that if they don't regain vision with reattachment, it's because of the chronic detachment and the retina being damaged more than the optic nerve being damaged, is my best guess.
Yeah. I was comforted by your quote of the long-term follow-up of epiretinal membranes, in that there can be slow improvement even out to 3 years. I think it's important for us as retina specialists when we're counseling these patients to remind them of that ahead of time. And then oftentimes we're counselors during the postoperative period saying that, the anatomy's been restored. All we can do now is wait, and encourage them that it's not over yet. Neuro tissue is slow to regain function even after the form or the anatomy has been restored. This is what the patient looked like post vitrectomy. You can see the resolving gas. Dr. Blinder, do you have to drain these macrocysts?
Great point, Brad. No, actually, you just want to reattach the retina, and usually the cysts will resolve on their own over time.
Yeah. Good. All right. Thank you for your comments on that. Okay, let's go to the next case. This is a 47-year-old with central macular defect following retinal detachment repair. Kevin, what do you think this is?
I like to see how the patient was repaired, but it certainly looks like a omega sign on the OCT, which is usually diagnostic of a subretinal perfluorocarbon liquid bubble. It could be a silicone oil bubble, but it's extremely unusual to get those in the posterior pole since those float up more. But yeah, I would say it's probably a subfoveal PFO bubble.
And unfortunately, I'm showing you just one single raster scan, but if you look at the near infrared, there is still some retained silicone oil in the eye. And not only that, there's probably multiple bubbles of perfluorocarbon liquid.
Yeah.
So you mentioned the omega sign. That's exactly what it looks like. How, any guys have any ideas of how you would approach this, or would you just leave it alone? I mean, sometimes retinal detachments, bad ones, were, you know, in a sense, the patient is lucky just to have the retina reattached. Do we need to go in and intervene any further? What would you do for this patient, if anything?
Yeah.
No. Oh, go ahead. Okay.
Go ahead, Thomas. I'd like to hear your opinion.
Yes, subretinal perfluorine creates an absolute scotoma. So if it's under the fovea, it has to be taken out. If it's away from the fovea, you can leave them alone, but the subfoveal one has to be taken out. Usually it happens in complicated cases, as you said, Brad, in patients with giant retinal tears, or in patients that the surgeon has performed a large relaxing retinectomy. Usually it happens when you have a lot of turbulence in the eyes. In the pre-valve era, it used to happen more often than now with the valve trocars, because the eye is stable. The way to remove it is, I like to use the 38 gauge catheter and directly aspirate the perfluorine bubble. Other surgeons like to mobilize the perfluorine bubble to the peripheral spot and then extract it from there. Both techniques work nicely.
Does the presence of multiple perfluorocarbon liquid bubbles, as seen on the near infrared, does that dictate one way or the other whether you should go after the individual bubble or try to mobilize and encourage coalescence of all the perfluorocarbon liquid bubbles into one big PFCL bubble?
I think I would go for the one right in the center, because I'm not going to mobilize the retina. If you mobilize the retina, then you really have to take them all, because then you're going to mobilize the other perfluorine bubbles.
How often do those, let's say this patient didn't have a subfoveal bubble and you just saw the peripheral bubbles, how often do those migrate? Let's say after the first few months post-operatively, are they pretty stagnant, or do you have to treat them to try and keep them in place?
A lot of times over time, you know, a few months out, they're pretty stable. So I that would be less likely to intervene a few months out.
Mm-hmm. Well, I'll show you the video in this case. So it's a little off screen, but hopefully we're going to center up. You can kind of see a reflex from the perfluorocarbon liquid in the foveal center. And there's one off to the side as well. But that is the cannula that Thanos described. So we aspirated that perfluorocarbon liquid bubble. The patient had a previous internal limiting membrane peel, so we had to harvest internal limiting membrane remotely and bring that in over to the hole that's created once you remove the perfluorocarbon liquid. And then we chose not to address the paramacular bubbles and the ones that were eccentric to the macula. Instead, we just surrounded them with laser in an effort to try to localize them and keep them from spreading down into the macula after the fact. This hemorrhage that you're seeing was purposely injected into the eye. This was a peripheral blood draw. And so we took blood in a sterile fashion and then injected it over the macular surface to utilize the body's natural fibrin glue from the hemorrhage to keep those internal limiting membranes in flap, the internal limiting membrane flaps in place so that they didn't dislodge in the postoperative period.
I think great technique, Brad. I certainly agree with your approach there. there's other approaches with, again, subretinal fluid injection beneath the macula, detach the macula, and then try to get them coalesced. But I agree with Tanos, maybe you're looking for more trouble than it's worth if you don't get all of it out. Ajay Curran at Wills, I think I mentioned before, described a technique where he peels the ILM and then he goes right over the bubble with a 25 gauge cannula, aspirates, and he says that the bubble moves right through the retina. And actually, I saw the video, one of his videos, and it's really an amazing thing. So we tried it recently, and it certainly went through the retina, but after producing a small hole. So I couldn't reproduce his results, but certainly something that it's worth thinking about. But I don't know if I do it right over the fovea.
Yeah, I use this like a 39 gauge subretinal cannula for this one. I was a little concerned about using a larger cannula because the bubble itself of perfluorocarbon liquid is probably less than 300 microns across. So I was worried about collateral damage.
Sure.
This is a few months after the fact. Oh, and we took the oil out at the same time. So one of the questions was, do you just go in and take the oil out, or do you try to address the perfluorocarbon liquid at the same time? We thought, since we're going to be in the eye anyway, removing the retained silicone oil probably made sense to kind of give them at least the best chance of some regaining of central vision. There was a modest improvement in vision, but we're still relatively early in the postoperative period. But you can see those multiple flaps that we put over the hole, and remarkably, the external limiting membrane has joined together. So I was a little surprised about that, but definitely happy about that. So hopefully the functional improvement will continue after the fact.
Yeah, great result so far.
I just wanted to show a few little diagrams, and I know this is not exactly accurate. This is a limitation of my artistic skills using drawing on PowerPoint, but for those of you who may not be familiar with perfluorocarbon liquid use, we will not uncommonly use it for special circumstances. It's heavier than water, so when a patient is supine on the operating room table, the perfluorocarbon liquid is injected. It goes down to the posterior fundus, and then we can use that to push the subretinal fluid up to the anterior break and then withdraw that subretinal fluid through a cannula. Of course, this does displace some of the subretinal fluid anteriorly past the break as well. So we'll then do an air fluid exchange over the top of it to sort of squeegee the subretinal fluid out from in between the air and the perfluorocarbon liquid, and then subsequently remove the perfluorocarbon liquid. Any techniques you guys use to try and avoid retained perfluorocarbon liquid when you indeed use it?
Yeah, Brad, early in the trials, we used perfluorocarbon liquid for everything, and my advice to avoid subretinal PFO is not to use it that much. I mean, it really, there's really only a few indications where you want to use it, and giant retinal tear certainly is the best indication because we don't have a rotating table that goes upside down anymore, so you have to have something to push against the retina to keep it in place. But yeah, I think you certainly don't want to inject it when you have significant PVR still in place, because then that makes the retina stiff, and then it's more likely to go beneath the retina. So you want to try to peel as much as possible, and you can peel under PFO a smaller bubble to provide countertraction, but you want to try to relax the retina as much as possible, and then inject it if you need to.
I think key is to reduce the turbulence in the eye, avoid large fluctuations in the IOP. For example, going from 25 to 60 to control hemorrhage frequently, that's going to create more bubbles. Even when the assistant puts the depressor around the eye to assist with the scleral depressed shaving, that has to be done really gently, because if you do it forcefully, it's going to create bubbles. Another technique is never to fill up the eye all the way up to the ports with perfluoron, because essentially the perfluoron in a non-complicated retinal detachment just stabilizes the retina so that you can do your shaving. So you can put perfluoron up to the posterior margin of the retinal break, and then with low turbulence, finish the case.
Yeah. I need to thank Dr. Elise Tom, one of our current second-year fellows, for helping me put these videos together. Also, to add to that, also, I try to avoid I try to keep the vacuum on the extrusion cannula in the event that there's some perfluorocarbon liquid in the cannula. I don't want that to inadvertently roll down the cannula and then deposit itself back into the eye as I'm trying to remove it, or even worse, move over to the giant tear and deposit a little bubble in the subretinal space. But I agree with you totally about decreasing the turbulence and reducing the scleral depression. That is helpful.
One other thing to start with is you initiate your injection to make sure that it's coalescing into one big bubble. You know, sometimes you put it in, you get lots of tiny bubbles initially. That if you work away from where the tear is or breaks, and let it start to coalesce and get into one large bubble before you continue to fill it, can make a difference.
Yeah. I'm sorry, this video is so fast, but that is the perfluorocarbon liquid going in, utilizing that technique that you described, Dr. Yu, trying to get one big bubble in. Okay.
Yes.
All right, the next case is a 35-year-old with vision loss following direct trauma to the right eye. Dr. Krummenacher, what do you think about this? Is this an intraocular foreign body?
What was his, yeah, my point, what was his direct trauma?
Yeah, so he was a landscaper operating a chipper shredder without safety glasses and felt a fairly significant impact to the eye, and then developed vision loss approximately 1 week after the incident. And he came in to see us 3 weeks later with a vision of 2100, intraocular pressure of 32, and a significant anterior chamber reaction.
This looks like more chronic than a trauma case, but it reminds me of this lady who was a secretary, and she got a staple in her eye that was ejected from a sheath of papers that her coworker was unraveling, and she got a subconjunctival hemorrhage. Went to the emergency room, they diagnosed a subconjunctival hemorrhage, and the next day she came to me with endophthalmitis from one of the arms of the staple went in her eye. So if there's any question that there's an occult entry, what I would do x-rays, but I doubt if that's this. It's like a more chronic problem, an inflammatory problem, obviously.
Yeah. Any techniques in the office you would do to kind of make you feel a little better about ruling out the intraocular foreign body possibility?
Ultrasound.
Yeah. I don't have an ultrasound to show you, but we did do this, an OCT over the lesion.
Yeah, so it's a choroiditis, retinitis,
Mhm.
vitritis.
And full thickness through the retina.
Mm-hmm.
Yeah. Okay, so I couldn't fool you. Never
No,
did.
he couldn't fool me.
Never
So
did.
Brad knows I've had 3 patients this season with toxoplasmosis retinitis, all harvested their own meat, and one of them had 2 recurrences in the same eye. So hunters in Missouri, this is a good year for hunting deer in Missouri. They legally tagged 260,000 animals, and many more were harvested untagged, and many more were tagged by automobiles. So it's a really huge problem. And all 3 of these patients, I diagnosed it twice with PCR, once with serology when the anterior chamber PCR was negative, and treated them all with Bactrim. And they all processed their own meat. And one of them did what is recommended. He harvested the meat himself, and he froze the meat for 28 days before he ground it into whatever they use. So he said it couldn't be this, it couldn't be toxoplasmosis, because processing might be like a professional would. So then after his PCR and his Bactrim and his sequential OCTs, he finally admitted that when he was skinning the animal in the wild, he took a sample of the meat raw deer tartare, if you will, and so he admitted that he ate raw deer meat. So that's my warning to all these hunters that, we're talking about 300,000 animals being provided for meat in Missouri last year alone. So in addition to freezing the specimen before you grind it up for 28 days, now you can get these rubber gloves that go up to the elbows. So when you're skinning the animal in the wild, you don't allow the toxo to enter little nicks and crannies in your skin. So deer hunters beware.
Yeah, good comments. This patient was treated with Bactrim and Timolol drops for the rise in pressure. And then once we had a few weeks of Bactrim on board, we started oral prednisone. And again, thanks to Dr. Tom, Elise Tom, one of our second year fellows who helped put these presentations together for this particular case as well. And you can see the evolution of that lesion, how it becomes more consolidated over time. And does that pigment help you, Dr. Krummenacher? Is that why you went straight for retinal choroiditis rather than thinking this was a true intraform body?
A lot of, besides congenital toxoplasmosis, a lot of toxoplasmosis is recurrent from a prior infection. So I don't think that pigment would occur from an acute foreign body, obviously. So immediately I thought more chronic thing than a retained foreign body.
Yeah, I thought this case really highlights the need for the historical perspective. It wasn't an immediate loss of vision. It occurred a week afterwards. That's important in potential cases of that may have some surrounding medical legal issues of on-the-job injury, as well as clinical acumen is demonstrated by Dr. Krummenacher in recognizing that this kind of fits the pattern of toxoplasmosis. And here you can see over time, the OCT shows the thinning of the retina that was involved in a resolution of that overlying vitritis. And this is a little fun fact. Toxo is a Greek word meaning bow shape. So in effect, this is an intraocular foreign body, but not of mineral origin. It's of animal origin, specifically toxoplasmosis. And this is just a micrograph showing toxoplasmosis in its natural habitat. All right, here's our final case of the day. 45-year-old with central vision loss and hearing loss. What do you think? Thanos, would you inject Syfovre for this patient?
I would not inject Syfovre or any other complement inhibitor for this patient. We see bilateral geographic atrophies in both macula. How old is the patient, Brad?
At this time, they're in their 40s, and I will show you 14 years later.
Yeah, having this appearance such at an early age, at 40 years old, that goes against geographic atrophy because of age-related macular degeneration. You can have other genetic diseases like choroidal areolar dystrophy. End-stage Stargardt disease can look like that, but we lack the pisiform flex here, so that's a low likelihood. You said that the patient has deafness too?
Yes.
Yeah, so there's a syndrome causing both geographic atrophies in the macula and deafness. So that can be evaluated with genetic testing. So yes, that would probably be the next step, do genetic testing to see if the patient has MIDD.
Okay. Yeah, so you listed the differential diagnosis already. So mitochondrial disease, you think this is mid, and you're obviously right. So maternally inherited diabetes and deafness due to a mitochondrial DNA mutation. It's important to note with these particular genetic syndromes that some genetic or IRD panels do not routinely look at mitochondrial genetic defects, so you have to specifically ask for the gene mutation or a mitochondrial panel if you suspect this potential diagnosis. I won't belabor this one too much because we're out of town, but I'll use it since it was recently shown or featured in one of the case of the months to encourage you to look at our website where we have the archived versions of case of the months if you want to read more about mid and other cases. This is the most recent one. Dr. Krummenacher graciously and for years has directed the publication of the Case of the Month. And if you wish to subscribe to it and receive these via email, do contact Nancy Boloski. In closing, I just want to thank all the doctors, my partners at TRI, as well as Nancy and Mike and our planning committee for putting this meeting together. And also, just on behalf of all of us, want to thank you guys for being partners with us in taking care of eye patients in St. Louis. We appreciate your support through the years. If you like these kinds of educational events and want to get more involved, please consider supporting the Retinal Research and Development Foundation, which makes these educational events possible through an unrestricted educational grant. And with that, I'll close and thank you guys for your time. Hope you enjoy the rest of the day.
Ladies and
Dr.
gentlemen,
Smith.
this concludes the Spring Retina Update 2023. You may now disconnect. Thank you and have a great day.
All right, that's it.
That's it.
That's it.